હેલો.
હેલો. પટેલ સર ચિંતન સર ઓપરેટ કરે છે તો એમને 20 મિનિટ લાગશે તો આપણે પછી લેશું.
We can start, and when he joins, we will have his
હા
blessing at that
અને
time.
ને હેમંત સર મારો ફોન નથી ઉચકતા સર આવી જશે થોડી વારમાં.
કોઈ વાંધો નહીં. We can
હા.
start.
Ma'am, we are live now, so we can
Yeah.
start the webinar. Yeah.
Meenakshi madam has not got the faculty link.
It is there in the group, ma'am, and I have pinned it also.
I told madam I am sending it again to her.
Yes, ma'am. Hemant sir is also joining, ma'am. 1 minute.
Link is sent to Meenakshi Ben, and she has attended also.
Yeah, I have sent it again, sir. She just called up. Yeah.
No, she has seen that link, and she will join.
In the meantime, let me start. A very warm
yes,
welcome
please.
to all the esteemed faculty members who have joined the program for today. This is the Happy Learning Masterclass 205th episode with SOGO in association with Anand, Bhavnagar, Dahod, Godhra, Nadiad and Vadodara societies. The brainchild of these Happy Learning webinar series, which are going on since the time of Corona, is none other than Dr. MC Patel, sir. Sir has been the past Vice President of Foxy, a very senior learned medical legal consultant in Gujarat, Ahmedabad. And sir is also a very active member of the Rotary and has done many camps in the Northeast as a part of his social service. Sir, we welcome you today and I request you to please introduce the August gathering and our chief guest for today, Dr. Shyam Desai, sir.
So before we go, let us have a lamp.
With the inauguration slide, sir.
Yes. Mehul bhai, we can start with prayer. So welcome to this Happy Learning Masterclass episode 205. And today, societies of Sogo, Anand, Bhavnagar, Godhra, Nadiad, and Vadodara have joined this webinar, and we are going to discuss labor room emergencies in this webinar. And again, next week also, the same topic will be continued, labor room emergency with different topic. I welcome Dr. Shyam Desai sir, who has kindly consented to be chief guest. He is always with us in any of our academic activity. Welcome, sir, and thank you for sparing time to bless us.
Thank you.
I also welcome Dr. Meenakshi Ben Patel, Dr. Chintan Thakkar, and Dr. Hemant Bhatt. They are guests of honor, and they all are always with us in our academic activity. Meenakshi Ben is past president of SOGOG, Chintan Thakkar is present president of SOGOG, and Hemant Bhatt is joint secretary of SOGOG with me. So welcome. I also welcome all the learned faculty, Dr. Divyesh Patel from Godhra, Hitesh Chauhan from Bhavnagar, Dr. Reshmi Banerjee from Baroda. They are going to chair very important first session, and speaker is Dr. Deepa Pitre, and she is going to discuss acute inversion of uterus in that very session. As far as second session is concerned, may I please welcome Dr. Monica Batra, Nadiyad, Dr. Ramaben Srivastav, Anand, Dr. Niket Patel from Anand. They all are going to chair second session, and Ashwin Shah is going to deliver about amniotic fluid embolism. And third session will be chaired by Dr. Sanjay Brahmbhatt, Dr. Nidhi Vasani, and Dr. Hitendra Somani. And we are going to discuss POXO Act. This is odd topic in this labor room emergency, but it was special request on part of Baroda Society, because so many of our friends have still doubt as far as implication of this POXO Act is concerned. So we are going to discuss that also. And then after, we are going to have very interesting panel moderated by Dr. Nitin Raithatta from Anand and Sonali Agarwal from Vadodara. And Dr. Jagdish Gohil and Archana Trivedi, both from Baroda, they are going to have their expert comment in that very panel. I also welcome all the learned panelists, Dr. S.P. Patel from Godhra, Dr. Jaina Shah from Nadiyad, Dr. Maitri Patel from Anand, Dr. Sujat Wali from Godhra, Pinky Kataria from Nadiyad, Dr. Binal Shah from Vadodara, Dr. Snehal Ravi Saheb from Bhavnagar, Dr. Ranjit Chaudhary from Bhavnagar, Dr. Dolly Ramnani from Baroda, and Dr. Jignesh Deliwala, treasurer of SOGOG. He will be also joining panel with his expert comment. So, and also, of course, my team, Dr. Monica Umardan, she is convener in whole series. She is from Solapur. Dr. Monica Gupta from Alwar, Dr. Deepika Lugani from Delhi, Dr. Satabdi Day from Siliguri, Dr. Nivedita Datta from Steel City Bokaro, and Dr. Megha Kamlapur from Kalaburgi. So they all are coordinator in this series, and they are working hard to deliver all these topics, etc., in this Happy Learning Masterclass web series. So as far as labor room emergencies are concerned, we all are obstetrician. We know when anything goes wrong in labor room during ongoing process of labor or just after delivery or so, it becomes a nightmare for any obstetrician. And how to get rid of and how to prevent all this, we are going to discuss in sequence in one by one all the webinar. So without wasting much of your time, welcoming you all the president and secretary of Joining Society and all the delegates. Thank you very much. And over to you, Monica. Yes, Monica. Yes, Monica, proceed.
Hello.
Yes.
Sir, am I
welcome.
audible?
Yeah,
yes,
yeah, you are audible.
Audible.
Requesting the Corona team to please share the slides. It's an honor and a privilege to introduce our chief guest, Dr. Shyam Desai, sir, today. He has been the past president of FOXY, my teacher. It is because of him who I have learned OBGY. He is a senior endoscopic surgeon at Hinduja Hospital and Nanavati Hospital, Mumbai. He has been the past president of the Mumbai OBGY Society in 2000, the past president of the Indian Association of Gynae Endoscopy from 2003 to 2005, the vice chairman ICOG in 2006, president of from 23 to 25. He's also been the chairman of the Maternal and Perinatal Health Committee, AOFOC, from 2009 to 2003. Sir, it is because of you that India stands on an international platform both at SAFOG as well as at FIGO. So we welcome you and we request you to please give your words of wisdom, sir, today.
Thank you, Dr. Monica. I'm indeed honored to be the chief guest for today's webinar. I have known Dr. M.C. Patel now for many years, and I know he's a true academician, a hard worker, a true Foxian, and has been at the forefront of most of the activities of Foxy over the last almost couple of decades. The webinar today is of an interesting topic. It is of obstetric emergencies, something which is our bread and butter for all these years that we've been practicing. And there are certain points in your practice in the labor room that stand out because they are life-saving. And for example, an acute inversion of the uterus, suppose a patient suddenly collapses, you have to know exactly the drill that one should follow when one is confronted with such emergencies. Also, another important aspect is postpartum hemorrhage, which requires an entire webinar on its own. We are also going to be subjected to extremely good information regarding the POXO Act. And therefore, I think this webinar is one of the most important webinars of its kind. And I wish the webinar all success, and Dr. M.C. Patel also all success in his endeavors. Thank you, Monica.
Thank you. Thank you, Shyam sir, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you for the same.
Okay.
Thank you, sir. It's an honor to share the platform with you. And I now would request Dr. Monica Gupta, madam, to please invite our guest of honor, Dr. Meenakshi Patel, ma'am.
Thank you, Monica, for the opportunity. It's my proud privilege to introduce Dr. Meenakshi B. Patel, ma'am. She's a director and consultant of Sunshine Global and Barodara Hospital, president of Society of Vaginal Surgeries of India, past president of MSV, past president of Sogos and Box, got Gujarat Gynae Excellence Award in 2020. As a president, she got a Best Society for SOGOG in 2018 and organizing chairperson of SOGOG 2018. Welcome, ma'am, and we request you for the words of blessings.
Hello, am I audible, sir?
Yes, ma'am. Yes, ma'am, you are audible.
Good evening, everyone. So, respected SOGOG President, Dr. Chintan Thakkar, Secretary Dr. M.C. Patel, Dr. Hemant Bhai, and rest of the all SOGOG office bearers, all the esteemed today's faculties, as well as respected presidents of Dahod, Anand, Vadodara, Godhra, Bhavnagar, and Nadiyad Society, and all the society members, those who have joined today. Dr. M.C. Patel has selected such a wonderful topic. Labor room emergencies are the critical situations that occurs in the labor room during pregnancy, labor, or delivery that require immediate medical attention to protect the health of mother as well as the baby. And in that cases, commonly problems like PPH, hypertensive disorders, eclampsia, fetal distress, along with cord prolapse, and so many things. But prompt recognition as well as coordination with rapid response that's involve the multidisciplinary teams is most important, and that can save the life of mother as well as the baby. Sir has selected such a wonderful topic, and now my best wishes for the sir. Sir is standing for the president of the 2026 next year. So let us join our hands together for the sir, and best wishes for the MC Patel sir for the next year presidentship 2026. He is standing for the elections. Thank you, sir.
Thank you, Meenakshi Ben, for good wishes and all the kind words. Of course, you are always with us in any of our activity, and we have worked together in SOGOG also. When you were President SOGOG, you have led SOGOG very efficiently. So thank you for sparing time for us in this webinar.
One thing I will like to say for the sir. Sir is a Sankat Mochan for all the Gujarat society members, as well as even in India also, sir is known as the Sankat Mochan Hanuman.
Thank you, madam. Thank you.
Sir, I spoke to Hemant sir also. He is also operating, sir. Both of them will join later, sir.
But
So I
we can
think
proceed.
yes, sir. So with this, I conclude that the inauguration is now over. And I would request Deepika madam to please conduct the first session, which is on acute inversion of uterus. And Dr. Deepa Pitre madam will be speaking about it. So over to you, Deepika ma'am.
Yes, I'll just go. So can we be sharing the slides? So good evening, everybody. It gives me great pleasure to introduce the chairpersons for our first scientific session on acute inversion of uterus. Our first chairperson is Dr. Divyesh Patel, sir. Dr. Divyesh Patel is the secretary of the Godhra Obstetrics and Gynae Society.
Madam, chemotherapy ના કેટલા dose હશે? માસી.
So Dr. Divyesh Patel is the secretary of the Godhra Obstetrics and Gynae Society and consultant obstetrician and gynecologist at Sharda Mangalam Hospital, Godhra, Gujarat. Welcome, sir. Our second chairperson is Dr. Hitesh Chauhan, sir. Sir is the secretary of Bhavnagar Obstetric and Gynecology Society. He is a consultant obstetrician gynecologist with over 10 years of clinical experience, specializing in high-risk obstetrics and gynec surgery, and is associated with MMA Maternity Hospital at Bhavnagar. Welcome, sir. Our
Thank you,
next
madam. Thank you
chairperson
for the input.
thank you, sir, is Dr. Reshmi Banerjee, ma'am. Dr. Reshmi Banerjee is the Vice President of the Vadodara Obstetric and Gynecology Society. She is a consultant gynecologist and menopause practitioner and a member of Foxy's Midlife Management Committee 2025 to 2028. And she's also a member of the Imaging Science Committee 2022 to 2025. So may I now invite Dr. Divyesh Patel and our chairpersons to kindly introduce our distinguished speaker for the day, for the first session, Dr. Deepa Pitre ma'am, who is the president of Godhra OB/GYN Society and who will be speaking on acute inversion of uterus. So can we have ma'am CV and can
I will introduce Deepa.
Yes, ma'am.
The
Please.
Reshmi here.
Yes, ma'am. Please.
Yeah.
Please.
So
Yes,
good
ma'am.
evening, everyone, and it's an honor to be a part of this webinar. And Dr. Deepa is the current president of Baroda Obstetric Gynec Society, and she's an associate professor and a very good one at the Jimiers Guthrie Medical College. She's an IVF consultant and a gem of a person, a personal friend. So not staying between the academics and the audience, we are eager to listen to Deepa now.
Yeah, thank you. Thank you so much, Reshmi. Thank you for the kind words. At the onset, I would like to thank Dr. MC Patel, sir, for giving us a platform. Vadodara OB/GYN Society was involved to its fullest, and we could never refuse sir for anything. As Madam rightly said, he is the Sankat Mochan of all the societies. So coming to the labor room emergency is a very, very good topic which we are discussing today. I will move ahead with my topic of discussion, that is acute inversion of the uterus. Yeah. So are my slides visible?
Yes, ma'am.
Yeah. So thanking and inviting all dignitaries for the presentation. Acute inversion of uterus, though rare, is one of the most dreaded emergencies in the labor room. Uterine inversion, the unexpected twist that turns triumph into turbulence in seconds, is the only sentence which I would like to say when I'm speaking about inversion of uterus. When the uterus is turning inside out, it is called inversion. Uterine inversion is the folding of the fundus into the uterine cavity into varying degrees. Now, the incidence actually varies between 1:2,000 deliveries to 1:23,000 deliveries. So definitely not so common, and especially with the advent of active management of third stage of labor, we should not be seeing acute inversion of the uterus in our labor room, is what I want. Now, coming to the incidence in a non-pregnant uterus, it could be related to the expulsion of an intrauterine tumor, a fibroid nodule, or an submucous pedunculated fibroid. So classifying the inversion into different types. One is according to the degree of inversion. When the fundus of the uterus has turned inside out, like the toe of socks, but the inverted fundus has not descended through the external cervical os, is known as an incomplete inversion. When I talk about complete inversion, the inverted fundus has passed completely through the cervix to lie within the vagina or often lie outside the introitus. Coming to the degrees, we can classify it as first degree when the uterus is partially turned out, second degree when the fundus has passed through the cervix but it has not come outside the vagina, third degree when the fundus is prolapsed completely outside the vagina, and a fourth degree where the uterus, the cervix, the vagina are completely turned inside out and are visible. So universally, we categorize it as first degree, which is incomplete inversion, second degree, that is complete inversion into the vagina, and third degree, that is complete inversion outside the introitus. There is a fourth degree, which is proposed, that is prolapse of the inverted uterus and vagina together. So in relation to the time interval between its diagnosis and the time of delivery, it could be acute if it is occurring within 24 hours of delivery, subacute if it is presenting between 24 hours and 4 weeks of delivery, chronic if it presents beyond 4 weeks of delivery or in a non-pregnant stage. So for the uterus to be inverted, what causes it? The uterus must be relaxed or a local atony of the uterus at the site where the placenta is inserting, especially when it is a fundal insertion of the placenta. So there should be one, that is fundal insertion of the placenta, and either of the two along with a spontaneous or an iatrogenic cause. So spontaneous in 40%, that is when there is an abnormally short umbilical cord or a functionally shortened cord by being wrapped around the fetal body, a sudden rise in intra-abdominal pressure due to either maternal coughing, sneezing, or vomiting, a morbid adherence of a fundally implanted placenta, which we have missed out, or sometimes connective tissue disorders like a Marfan syndrome, which is a very rare condition. Coming to the iatrogenic cause, most commonly an acute inversion will occur if there is mismanagement in the third stage of labor. Pulling the cord when the uterus is atonic, while combined with fundal pressure, that is increased expression of the placenta while the uterus is relaxed. It is the most common cause which is leading to acute inversion of the uterus. A faulty technique in the manual removal of placenta, or while separating the retained placenta from the wall, a portion may remain attached, and as the placenta is withdrawn, the fundus is also withdrawn along with it. So coming to the pathophysiology, what happens in an complete inversion? Once the fundus passes through the cervix, the cervical tissue functions as a constricting band and edema rapidly forms around it. The prolapse mass then progressively enlarges and it increasingly obstructs the venous and finally the arterial flow, contributing to the edema. So clinical presentation can be a large boggy mass appearing at the introitus with or without the placenta being attached. Other signs and symptoms are as follows: severe and sustained hypogastric pain in the third stage of labor, shock. Now shock, initially neurogenic, later hypovolemic. Shock initially is out of proportion with the amount of blood loss. This is the most common presenting symptom with which the patient will present. Woman becomes sweaty with bradycardia because of parasympathetic stimulation, because of the pulling of the peritoneal, the infundibulopelvic ligaments, the ovaries being stretched. Profound hypotension can follow and rarely cardiac arrest. In short time, there is marked hemorrhage and a hypovolemic shock, which follows immediately. So, in a per abdominal finding, if you are seeing in an incomplete uterine inversion, the fundus of the uterus may appear to be normal. Only in a thin woman, it is possible to feel the fundal dimple of an incomplete inversion. In a complete inversion, uterus is not palpable per abdomen. At vulva, you can see a pear-shaped mass seen protruding outside the vulva with a broad end pointing downwards, reddish purple in color. Bimanual examination confirm the diagnosis by detecting the inverted body of the uterus and above it the encircling ring of the cervix. So coming to the differential diagnosis, it could be an inversion of the uterus, obviously, a uterine rupture, prolapse of the uterine tumor like a submucous fibroid, a large endometrial polyp, passage of a subcensurate lobe of the placenta. So coming to the management, Prevention. Firstly, it is most important to prevent, as I told you, do not employ any method to expel the placenta when the uterus is relaxed. The first and the foremost thing, patient should be instructed not to change her position. Pulling the cord simultaneously with fundal pressure should be avoided, and manual removal of placenta should be done in a very proper manner. Starting from the edge of the placenta is separated by keeping the back of the hand in contact with the uterine wall with a sweeping movement in case we need to remove the placenta manually. So coming to the management of acute inversion of uterus, delay in treatment increases the mortality. So the number of steps to be taken should be very immediate and simultaneous. Before shock develops, when one is on the spot when the inversion is happening, try immediate manual replacement even without anesthesia if not easily available. So the principle being, the part of the uterus which has come down last should go back first. Procedure. If the diagnosis is made immediately after inversion has occurred, as I said, then the same degree of relaxation of the myometrium and the cervix, which is required for the inversion to occur, will allow the uterine replacement very easily. The gloved hand is lubricated with a suitable antiseptic cream and placed inside the vagina. The uterine fundus, with or without the attached placenta, is cupped in the palm of the hand. The fingers and the thumb of the hand are extended to identify the margins of the cervix. The whole uterus is lifted upwards towards and beyond the umbilicus. Additional pressure is exerted with the fingertips systematically and sequentially to push and squeeze the uterine wall back through the cervix. This, mind well, is the best way to reposit the uterus immediately if you have diagnosed on-spot uterine inversion. Sustained pressure for 3 to 5 minutes to achieve complete replacement is necessary. Apply counter support by the other hand placed on the abdomen. Once the fundus has been replaced, keep the hand in the uterus with rapid infusion of oxytocin to give the contraction which is necessary for the uterus to get completely, very well contracted. Initially, bimanual compression aids in control of further hemorrhage until the uterine tone is recovered. When the uterus is felt contracting, the hand is slowly withdrawn. If the placenta is attached, it is to be removed only after the uterus becomes contracted. If the placenta is partially attached, it should be peeled out before the replacement of the uterus if peeled off easily. Now, if the patient presents late, within 1 to 2 minutes from the occurrence of inversion, the cervix and lower segment starts clamping down upon the inverted part of the uterus. Increasing congestion, edema of the inverted fundus starts happening, making manual replacement without anesthesia very difficult. So if the first attempt at immediate manual replacement of uterus fails, move to the following sequence of events immediately. Call for assistance. Anesthesiologist should be available immediately. Assistance of an SOS obstetrician or nurse immediately should be there to help. Elevation of the foot end of the delivery table may relieve the tension on the viscera and reduce the pain and shock which is occurring. Establishing 2 wide-bore IV cannulas, sending blood for grouping and cross-matching, rapidly infusing 1 to 2 liters of crystalloid. Mind well, this is very, very important to prevent hypovolemic shock, because though initially shock is neurogenic, as I said, hypovolemia will follow soon due to hemorrhage. Catheterization, prophylactic antibiotics should to be given. If pain being a dominant symptom, you can give small doses of morphine or pentazocane with atropine. If the inverted uterus is prolapsed beyond the vagina, at least replace it into the vagina. Patient should be shifted to the operation theater meanwhile. And coming to the anesthesia part, if shock and cardiovascular instability is there, general anesthesia should always be preferred. One of the commonest agents being sevoflurane and isoflurane to aid uterine relaxation. Halothane is associated with rare myocardial irritability and arrhythmia and hepatotoxicity. Therefore, the other 2 drugs are preferred. When the vitals are normal, spinal anesthesia can be given. If the patient is already given epidural anesthesia for delivery, then it may be continued. When anesthetic facilities are not available, replacement will have to be undertaken in the combination of IV narcotics, combined paracervical and pudendal block, and inhalation anesthesia as available and feasible. If general anesthesia does not produce adequate uterine relaxation, or if the patient is in regional anesthesia, tocolytics may be necessary. So if a patient is hypotensive, magnesium sulfate 2 gram IV bolus can be given to relax the cervical contraction ring. If the patient is stable, a nitroglycerin drip can be given. 1 ampule of nitroglycerin, that is 5 milligram in 1 ml solution, is diluted in 100 ml normal saline. This gives a concentration of 50 microgram per ml. Draw 20 ml in a syringe, 4 ml given IV, and repeat it at 2 minutes interval SOS in a normotensive patient, and repeat it at 2 minutes interval in hypotensive patient only after correcting hypovolemia. In all the cases where oxytocin and prostaglandins have been given previously, higher doses of nitroglycerin may be required. Onset of action is between 90 seconds and it lasts for 1 to 2 minutes. Maternal side effects, definitely peripheral vasodilatation and reduced venous tone. So rapid infusion with crystalloid is needed in patients who are hypovolemic. Peripheral vasodilatation responds well to adrenaline, and uterine relaxation responds well to oxytocin. Terbutaline can also be used as a tocolytic agent. Manual replacement of the uterus as described above. And as soon as the uterus is restored to its normal configuration, the agent used for uterine relaxation should be stopped immediately. Simultaneously, oxytocin is started to contract the uterus. So if there is delay, if there is delay in the procedure and if manual replacement fails, then O'Sullivan's hydrostatic replacement technique is used. Prerequisites being, make sure that the uterus and vagina have no lacerations. Confirm that if they are found, they should be sutured to prevent further blood loss. Principle of this hydrostatic replacement technique being, a large volume of saline at a body temperature, 3 to 5 liters, is poured into the upper vagina. This distends the upper fornices, which serves to open up the cervical ring and allows replacement of the uterine fundus. Until replacement is effected, a towel soaked with warm hypertonic saline is draped over the inverted uterus to reduce the edema as much as we can. Use a douche and rubber tubing with warm sterile fluid at 3 feet height, or a 1 liter bag of warm saline with a pressure infuser. Rubber tubing is placed in the posterior fornix by one hand, which also cups the fundus. The other hand seals the introitus around the wrist so that there is no leakage of the fluid. Alternatively, the tubing can be attached to a Silastic vacuum extractor cup, which is placed inside the introitus and may provide a better seal. As the vaginal wall distends, there is increase in the intravaginal pressure. The fundus of the uterus rises and inversion can be corrected. Once this is achieved, fluid is allowed to escape slowly from the vagina. In rare delayed cases, manual replacement with or without hydrostatic technique may be unsuccessful, and in such cases, there is no other option but a surgical replacement which will have to be done. So in that case, patient is cleaned and draped and with the head in Trendelenburg position. Catheterization is done. A midline laparotomy can be done. Mobiles which are packed upwards and away from the uterus. The obstetric surgeon places his or her hands in front and back of the lower segment with the fingertips below the level of the inverted fundus, as shown here. With progressive pressure on the fingertips with both hands, which flip up simultaneously, the internal dimple is replaced with a rising fundus. Uterine perfusion returns gradually. If this technique fails, we have the Huntington's operation which can be performed. In this, following steps are taken. Exteriorize the uterus and the cervical ring may be stretched. Locate the cup of the uterus formed by the inversion. Dilate the constricting cervical ring digitally, and stepwise traction on the funnel of the inverted uterus or the round ligament is given with the help of an Alice forceps. Reapplied progressively as the fundus starts emerging out. The obstetric Wenthouse is another useful instrument which can be applied to the inverted uterine fundus. Reduction of the inverted uterus after traction with the Wenthouse is shown in this picture. Instead of the Alice forceps, alternatively, vacuum cup can be used in the Huntington's procedure. So if that is not possible, then there is the Holtein's procedure, which also can be used. Incision is made posteriorly through the cervix, relieving the cervical constriction to increase the size of the ring and allowing traction on the round ligament with the replacement of the uterus with subsequent repair of the incision from inside the abdomen. If we speak about vaginal routes, there is Spinelli's method, Kastner's method of operative methods. These are from the vaginal route, or ultimately hysterectomy if nothing is working out. So in short, Spinelli's method is anterior colpotomy, which is done and incision on the constricting cervical ring is given for the replacement of the uterus. When I talk about Kastner's method, it is posterior colpotomy which is done and incision of the cervix similar to that of Spinelli's method is done for repositioning the uterus. If failure of conservative surgery, family is completed, and if we are suspecting sepsis, if the patient has presented late, then hysterectomy is the only choice we are left with. Post-operatively, whatever method of uterine replacement is used, it should be followed by one, oxytocin and oxytocin to keep the uterus well contracted for 8 to 12 hours. This should definitely not be missed. So an oxytocin drip along with prostaglandins, 15-methyl PG2 alpha. Initially, after correction of inversion, a carboprost can be given in the doses of 0.25 milligram intramuscularly or intramyometrically also 0.25 milligram diluted in 5 ml and given at 2 sites in the uterine fundus. Duration of action can be up to 6 hours with carboprost. Broad spectrum antibiotics definitely given if not given prior. So what are the complications when we speak about inversion of the uterus? There can be postpartum hemorrhage due to uterine atony, which was the underlying cause for the uterine inversion. Hypovolemic shock and all its consequences. We all know the consequences of hypovolemic shock, which we all dread. Vasovagal shock due to the severe pain and stretching of the ligaments and the peritoneum, which is leading to parasympathetic stimulation. Endometritis because of sepsis. Infection of the adnexa so many times. Necrosis of the ovaries is also seen. Necrosis of the ovaries due to compression of the ovaries as they are drawn inside. Damage to the intestine, septic paralytic ileus. Chronic inversion. Recurrence of inversion in later pregnancy, increased risk of rupture of uterus in the next pregnancy when surgical procedure is done to resolve inversion, increased risk of C-section in subsequent delivery, chronic pelvic pain if chronic inversion is not treated on time. So, coming to prevention, many cases of acute uterine inversion may result mainly from the mismanagement of the third stage of labor in women who are already at risk. So, maneuvers to be avoided is excessive traction of the umbilical cord should not be given. Please follow active management of the third stage of labor where we say a controlled cord traction should be given. Excessive fundal pressure, a big no. Excessive intra-abdominal pressure to be avoided. Excessive vigorous manual removal of placenta also should not be done. Recently, Vijay Raghavan et al. Reported a case where acute inversion of the uterus was managed under laparoscopic guidance, citing the advantages of laparoscopic surgery as the reason for the procedure. Consideration, however, needs to be given to the woman's hemodynamic status and the possible effects of pneumoperitoneum. So, laparoscopic appearance of an inverted uterus, he has shown a 5 mm forceps being used to press down the top of the inverted uterus. Partial reduction achieved. Further reduction was completed using a 10 mm blunt-tipped Teflon rod to press down on the top of the inverted uterus, and a complete reduction was being achieved, is what he has stated. But when we speak about uterine inversion, the only thing I would say is recognize it fast, replace it faster. That is the bottom line, which should be there when we talk about acute inversion of uterus. Thank you so much for the patient hearing.
So Deepa, it was a very crisp and to the point presentation and extremely informative, especially the step-by-step, the way you said to how to reduce the inversion. And
Yes.
I think even I have become a little wiser after this talk. So thank you for that wonderful presentation.
Thank you so much, Reshmi.
Because it's such a rare complications.
Yes.
And sometimes we may even forget how to do it correctly after if you have not seen for many years. So one question I would want to ask that in your practice as with the medical college experience, how many, what is the frequency in which you see uterine inversion when the delivery is conducted by residents in the college and coming from the periphery, and what are the commonest methods or what are the most frequent methods you have used?
See, most of the time, the commonest thing which we have done is immediate replacement. If we are there in the labor room or if we are being called by the resident when they diagnose inversion and they try to reposit it back also, but they fail. Once or twice I have been called during cesarean section when one of my senior residents just pulled the placenta, tried to pull out the placenta, and there was focal adherence and there was complete inversion in a cesarean section, which I had to reposit back. And then because there was atony of the uterus, I had to go ahead with some other techniques to prevent atony of that uterus. The placenta was removed manually in the cesarean section because spontaneous expulsion didn't occur. And once
Okay.
or twice we have received, we do receive patients from the periphery, but I'm happy to share that with good referral practices, people have started using active management of third stage of labor very well now, and these kind of things are being prevented. So rarely in last 2 years, I have had only one patient who has been referred from the periphery with acute inversion of uterus. And that day, the patient came after 2 hours and was hemodynamically very unstable. So patient did not come. Mortality is very high if the patient is
Yeah, because
coming.
of mainly first thing is shock and second is the bleeding.
Yes.
Shock, the shock itself from the
Shock
inversion
itself. Yes.
is the reason for the mortality.
Yes.
And one more question be allowed if from the chairperson MOC?
Yes, very
Yes,
quickly.
ma'am.
Okay. Would you, other than oxytocin, would you advise any other form of surgical technique to prevent atony in a case of acute inversion, like a compression suture or something?
But when
If you are doing an LSCS and there is atony,
yes,
okay?
yes, yes,
And you have deposited the inversion, you have started oxytocin, but if still the atony persists, would
Yeah.
you?
I have done Beilin's suturing along with uterotonics,
Okay,
and
but
it
that
has
itself
helped
would
me.
also.
Yes, yes,
Okay.
it has helped
Thank-
recovering the atony.
Thank you, MC sir, for allowing that question.
Dr. Hitesh, any comment as a chairperson?
Good evening to all of you. First of all, thank you organizing committee for giving me opportunity as a chairing this wonderful session. And uncommon but most critical condition that is the acute inversion of uterus. And Madam Deepa Madam has very nicely elaborate the situation and acute inversion of uterus. Nicely describe the classification degree and basic step and easy to remember and how to practically do. Madam has described that we have to fast diagnose and per abdomen we have to see the if uterus not palpable and per vaginal pear shaped mass, it typically classified and diagnosed the inversion of uterus. And Madam has very nicely basic and practical step given as soon as possible, immediate manual replacement and keep the pressure 3 to 5 minutes. And first of all, ask to staff call for help and elevate the foot end of delivery table. It's most important step. And otherwise, all medical management. And last but not least, recognize fast and replacement fast. Very nicely, Madam has taken lecture and described very nicely. Thank you. Thank you so much, Madam.
Thank you, Reshma ma'am and Hitesh sir, for chairing this session. And Deepa ma'am, it was a very informative talk. Before we move ahead with the next session of amniotic fluid embolism, which will be taken by Nivedita madam and the speaker is Ashish sir, I would like to introduce our guest of honor, Dr. Chintan Thakkar sir. He is from BJ Medical and Civil Hospital, Ahmedabad. He is in private practice in Bharuch since the last 16 years. He has presented many lectures at various conferences and he has conducted a number of workshops in his own hospital, the Bharuch OBGY Society, as well as SOGOG and Foxy. He has also promoted an innovative way of operative laparoscopy with 5 mm main port, making minimal access surgery very less invasive. We welcome you, sir, and for your words of wisdom, sir, today.
Thank you, Monica ma'am. Thank you, MC Patel sir. Thank you, all the learned faculties. Thanks to all the stalwarts of medical college for giving me an opportunity to be a part of this wonderful academic event. Now, I always believe that labor room is a place, which is always a source of adrenaline rush for us all gynecologists. And it time to time, no matter how senior we are and how experienced we are, it continues giving us some surprises, some jerks, and some I can say opportunities to save lives. But then, okay, this is the labor room emergencies is always a thrilling thing, and I think, the importance of such good webinars and educational events is that, we get more mentally prepared. No matter, suppose we may have during residency or during our practice, we may have managed so many cases of inversion. But, with after Deepa madam's lecture, we have come to know what are the specific techniques for, management in different routes. So the having more knowledge, it refines, our understanding of this critical emergencies, and that helps us to act better and act faster to save lives of our patient. I always appreciate the efforts of Dr. M.C. Patel sir and all the stalwarts who have taken a lot of pains and efforts to make this sort of sessions very interesting and very informative and worth. And I appreciate particularly the involvement of so many professors and faculties from medical college, because these are our gems. They do come across a lot of emergencies and referrals and some of the rare complications. And I'm happy to have my friends like Dr. Nitin Raitata, Dr. Ashish Sasa, Dr. Shonali, and so forth, Dr. Ashnam and Dr. Binalwin. So once again, good evening to everyone, and thank you very much for making me a part of this wonderful event. And one last request to join the SOGO, which has come very near in December, in maximum numbers, and making this our Gujarat Zone event again once again a successful and an enjoyable event. Thank you so much.
Thank you, Chintan Bhai, for sparing time for us to bless this webinar. Of course, is it a part of a SOGOG activity, and you are always there to boost any activity related to SOGOG in academic or any other social public awareness also. So thank you for sparing time.
Thank you. It's a pleasure, sir.
Thank you, Chintan sir. Thank you for joining right from the OT. And now I request Nivedita madam to please take over for the second session.
Thank you, Dr. Monica, and good evening, all learned faculties in this group, as well as all the audiences who are listening to these to the learned faculties today. It's indeed an honor to be there. Thank you, Dr. M.C. Patel, sir, and Dr. Monica for considering me. And we have stalwarts in session 2. After a very interesting session 1 on uterine inversion, we have a very interesting session 2 with stalwarts as chairpersons. I request Dr. Monica Batra, the first chairperson. She's the secretary, Nandiad Obs and Gynae Society. She's a GNO as well as a fetal medicine expert with interest in social health. She's been a gold medalist with experience in gynae, obs, laparoscopy, as well as maternal and fetal medicines. She has posters and papers in ICOG, and she has been a staunch supporter for educative and preventive aspects of comprehensive women's health, including cervical cancer and breast cancer awarenesses. I request Dr. Monica Batra to please introduce the topic for session 2 before I call upon the next chairperson. Or you want me to introduce the next? So Dr. Monica will introduce the topic, and then we have Dr. Rama Srivastava. Ma'am has been the past president of Anand Obs and Gynae Society. She's an academician, as you can see from the innumerable with the innumerable posts that she has held in training as a trainer as well in medical colleges. She's a professor. She's a professor of Gynae and Obs department of Shri Krishna Hospital, Karamsad. She has she's got special interest in high risk obstetrics as well as awareness among adolescents. She has special interest in cultural activities of local clubs and associations. And very interestingly, she's a Sangeet Visharad in vocal music. She's also an excellent compare. So I think, she would have been an excellent person to be moderating any session and any cultural program. The next chairperson His credentials at a glimpse is Dr. Niket Patil. He is the Secretary, Anand Dobbs and Gynae Society, with multiple awards and publications. He has a diploma in basic and advanced minimal access surgery, as well as a fellowship in the same. He has a diploma in reproductive medicine, and all from Kiel University, Germany. He has got a specialized training in fertility preservation and ODCP. His major areas of interest, as is evident, are endoscopy, infertility, endometriosis, fertility preservation, as well as PCO. With multiple publications in PubMed journals, he is the third chairperson in this series. I now call upon the first chairperson, Dr. Monica Batra, ma'am, to please introduce the topic, which is of very special interest today. The topic to be introduced. Dr. Monica Batra, ma'am.
Yeah. Am I audible?
Yes, ma'am.
Okay, good evening, everyone. At first, I would like to thank Dr. Nivedita Madam, Dr. MC Patel sir for giving me opportunity to be a part of this nice Zoom meeting. It's my pleasure to be part of this. We are here to discuss an important and rare obstetric emergency, that is amniotic fluid embolism. It is one of the serious and unpredictable complication is in obstetrics. That is a nightmare for all obstetricians. So here we are for that. Amniotic fluid embolism is not just about knowing the pathology, it is about improving preparedness, strengthening protocols in our hospitals, and ultimately saving lives of the mother. So in today's session, we will help us to deepen our knowledge of the etiology of amniotic fluid embolism, risk factors, challenges, and the latest evidence-based management approaches. So I'm honored to chair this portion, and now I would like Rama Srivastava ma'am to invite our speaker for nice talk on amniotic fluid embolism. Thank you.
Thank you, Dr. Monica. Thank you, Dr. MC Patel, sir, for inviting me. And good evening to all. It's my pleasure to invite Dr. Ashish N. Shah. Dr. Ashish is the professor and head of GMERS Medical College Gynec Department, Gothri, Vadodara. He was also the ex-dean, past president of Baroda of OBGY Society. He's also the MCI Inspector for Assessment of Colleges. Has a lot of international achievements and national achievements to his credit. We can see it on the slide. Interestingly, he has written, directed, and performed stage plays on social issues like female feticide, blood donation, child labor, child education, save water, etc. And we would welcome Dr. Ashish to deliver this important topic. Thank you.
Thank you, chairpersons. At the outset, I would like to thank Dr. MC Patel, sir, for inviting me again to the 205th Happy Learning session. Thank you so much, sir, and thank you all the president secretaries of all the societies and all the faculties who are here with me today. So I just wanted to confirm whether my slides are visible or not.
Yes, sir. But could you please make them in the slideshow? Yeah, thank you, sir.
All right. So as Dr. Monica rightly said, that this is a situation where we all need to be prepared and we all need to be aware of what is going to happen. So I would begin with taking everyone to a moment in our lives as obstetricians facing this patient. A 32-year-old third gravida induced at 40 plus 3 weeks without any significant medical or obstetric history. 5 minutes after reaching full dilatation, she complained of feeling unwell, then became breathless and dizzy, hypotensive, cyanosed, and suddenly lost consciousness, all within just 5 minutes. And her pulse was not recordable. The anesthetists around initiated cardiopulmonary resuscitation. CTG showed fetal distress. She was delivered by vacuum extraction, but developed atonic PPH with significant blood loss, which was managed by medical management and then blood component transfusions. She developed pulmonary edema and DIC, was kept on inotropic support under the ICU care. And over a period of next few days, she developed multiple organ failure, ultimately succumbed to irrecoverable brain injury. We do not want such scenarios to happen anymore in our labor room. For this patient, the initial clinical presentation of sudden cardiopulmonary instability, followed by DIC, and then the postmortem finding of fetal squams in the pulmonary circulation confirms the diagnosis of amniotic fluid embolism. So what I'm going to do now is divide my talk into 4 parts. The first one is a general about introduction. Second part is pathophysiology. Third part is diagnosis. And the fourth part would be the management. So to introduce the amniotic fluid embolism historically, Ricardo Mayer from Brazil was a person who first wrote in a Brazil medical journal as embolia pulmonar amnioserosa. And he stated that consider a type of embolism never mentioned in literature so far with presence of fetal debris in maternal circulation. However, it was not taken very well at that point of time. And later in 1941, Steiner and Lushbeck came up with an article published in JAMA where they have mentioned series of 8 autopsies where extensive fetal material in pulmonary vasculature was found. And then amniotic fluid embolism was established as a distinct clinical syndrome since then. We have come a far way from the first paper, but we have not progressed so much in the management, and that's where the research should focus now in the next few years. And it has been noted that in our part of the world, we frequently diagnose amniotic fluid embolism as a cause of death when we are not able to find out any other reason. But we need to be more specific in the coming years as the entity is becoming more specific and more defined. So the definition is the syndrome marked by sudden cardiorespiratory collapse and disseminated intravascular coagulation during labor or immediate postpartum period due to the amniotic fluid and fetal components entering the maternal bloodstream, leading to a series of events causing critical obstetric emergency. Another term coined is anaphylactoid syndrome of pregnancy, and the name was proposed because the clinical manifestations were considered to be a maternal immune response to a fetal antigen rather than just a physical obstruction of the pulmonary circulation by fetal material. However, amniotic fluid embolism remains the commonest term in the clinical practice today. When we talk of how frequent the condition is, there are a lot of gaps in our understanding of the disease. That's because it's a rare condition. There are no definitive diagnostic criteria for many, many years. It's sudden in onset with a quick progression, and histopathological diagnosis may not always be possible. So from whatever data we have, the incidence ranges anything between 1 in 8,000 to 80,000 deliveries, but we are slowly moving towards a diagnosis of about, let's say, 6 to 7 per 100,000 pregnancies. The ICU mean stay is 3 to 5 days, but it can vary depending on the case and the insult that has occurred. The case fatality also has a wide range from 20 to 70%. And contribution to maternal mortality, if we take all causes of maternal mortality, 10% of all maternal deaths worldwide are because of amniotic fluid embolism. Perinatal mortality is around 20 to 30% if treated quickly, but otherwise, if not delivered, then that also we lose the newborn as well. Coming to the second part, which is pathophysiology, it is important for us to understand the pathophysiology so as to manage it appropriately. And our knowledge in terms of pathophysiology has increased over a period of years. It's generally a biphasic response, which occurs in quick succession. And the insult, as we know, is a placental barrier disruption. It can be placental attachment, cervical veins, or uterine surgical incisions from where the amniotic fluid and the fetal tissues enter the maternal circulation. The fetal tissue could be squamous cells, mucin from the meconium, fat from the vernix or hair, and the amniotic fluid could be leading to or adding the tissue factor, platelet activating factor, arachidonic acid, cytokines, and thromboxanes. Now, the phase 1 immediately starts, and that's the cardiopulmonary phase, which is because of the abnormal maternal response, beginning with the profuse release of procoagulant factors, which includes histamine, endothelin, leukotrienes, and many more. And that leads to pulmonary vasoconstriction, bronchospasm, and a quick cardiovascular collapse. Also, there is a release of inflammatory mediators, which is little later, not too late, but let's say about 10 to 15 minutes later. I mentioned multiple inflammatory mediators which are released. The phase 1, the details of phase 1, there is initially pulmonary artery vasoconstriction that leads to right ventricular failure. And the right ventricular failure later on ends up in left ventricular failure because of myocardial ischemia, which is occurring due to acute lung injury. On the other side, the phase 2 sets in where there is, because of the inflammatory mediators circulating, activation of the coagulation cascade starts. It leads to quick DIC and DIC followed by a significant massive hemorrhage. This all also leads to uterine atony because of hypoxia, eventually leading to multiple organ failure, cardiorespiratory failure, hematological and coagulation disturbances, hypoxic brain injury, renal failure, and liver failure. So to sum up, the multi-organ failure of AFE could look like this. Almost all major organs of the body gets affected. Most importantly, I want to understand this. I want to explain this slide that we do not have much time. Though it's a biphasic event, the phase 1 manifests just within 5 minutes of insult, and phase 2 manifests within 20 to 30 minutes of insult. That means we have to act quickly, rather we have to diagnose quickly and we have to act quickly. So this is a very important slide in terms of time management and keeping us ahead of the disease. Coming to the third part of the talk, which is clinical presentation and diagnosis. As I said earlier, that we did not have a proper consensus about how to diagnose amniotic fluid embolism, but we have come a long way and now we know a lot of things about it. So first of all, the risk factors. The strong evidences are with induction of labor by any method, use of oxytocin for induction or augmentation, assisted delivery increases the risk by threefold, amnio infusion also increases the risk by threefold. Importantly, placenta accreta spectrum disorders increases the risk by tenfold. Previously, it was thought that the amniotomy, that is rupture of membranes that we do, artificial rupture of membranes, and cesarean, both increases the risk. But a lot of recent studies have said that they are not the risk factors and should be removed from the list. However, I would like to wait for a few more years before we say that they are not risk factors. There are many other maternal, fetal, and placental risk factors which I have mentioned, and there is a huge list, but they could be supplementary. We need to focus on the strong risk factors. Clinical presentation would be in terms of hypotension and fetal distress, which are present in almost all cases. This is one recent study published in British Journal where they have analyzed around 1,000 patients have come up with this data. Pulmonary edema, cardiorespiratory arrest, cyanosis, and coagulopathy follows. But most importantly, for our quick diagnosis, we need to remember a triad of hypoxia, hypotension, and coagulopathy all occurring very quickly and within just minutes. UK observation and surveillance system criteria were established in 2002-2003 for amniotic fluid embolism, which says either few of these conditions should be present or post-mortem diagnosis of the fetal squamous or hair in the lungs. Now, which condition should be present when the acute maternal collapse occurs? Acute fetal compromise, cardiac arrest, cardiac arrhythmias, coagulopathy, hypotension, maternal hemorrhage, some of the premonitory symptoms, convulsions or shortness of breath. These are the few initially suggested, and now we have what is known as the Society of Maternal Fetal Medicine criteria. They have clubbed up with Amniotic Fluid Embolism Foundation, and they have come up with these criteria, which are the most recent ones, and they are from 2016. It includes all 4 criteria. They are more stricter. Criteria 1 is cardiopulmonary collapse or compromise, which can be suggested by either an arrest, hypertension with systolic blood pressure less than 90, or a respiratory compromise with hypoxia less than 90%. Criteria 2 is presence of DIC. The overt DIC must be documented after the initial symptoms and signs as per ISTH definition, which I'm going to explain in the next slide. And the coagulopathy must be present before the significant blood loss can attribute to it. So this DIC is not directly related to hemorrhage. It is present prior to that. Third criteria is onset of symptoms. The SMFM says that it should be during labor or within 30 minutes of the placental delivery. Criteria 4 is absence of fever. So temperature should not be more than 38 degrees centigrade during labor. Presence of squamous cells in the pulmonary circulation of the mother is no longer a criteria for amniotic fluid embolism, as the clinical presentation is more important than this criteria. Now, coming to the criteria 2, that is diagnosis of DIC, we need to have the International Society on Thrombosis and Hemostasis criteria to label that there is DIC. A total score of 26 or higher is considered over DIC, but score more than 8 attributes the patient to be qualifiable for the diagnosis of AFE. So we take into account 3 things: platelet count, prothrombin time, difference between the case and control, and the fibrinogen level. And depending on that, there is a pregnancy modified ISTH scoring. And as I said, we have to sum up these 3 scores. And if it is more than 8, the patient qualifies to be into the category of AFE. And 26 is because when 26 or more is there, then it is the over DIC, which is already a late stage. Now, these criteria are there for last 8 years or so. So it also needs a revision. So there are few proposed modifications. Number 1 is inclusion of premonitory signs, which can be seizures, agitation, anxiety, feeling of imminent death, confusion, and fainting. There are critical clinical findings like coagulopathy, pulmonary hypertension, and neurological symptoms, which needs to be included. And though commonly the symptoms present within 30 minutes of the placental delivery, they can present within first 48 hours. So that may also need a revision. And if there are cases where during second trimester termination of pregnancy also there is amniotic fluid embolism. So these are a few proposed criteria, but they are yet not into the definitive diagnosis as per the research. As I said, this is a clinical diagnosis, but it's a diagnosis of exclusion. That means we need to rule out all other possible conditions which can mimic similar signs and symptoms. I have highlighted a few of them: eclampsia, pulmonary embolism, myocardial infarction, anaphylaxis, and sepsis, which are closest to the clinical picture of the amniotic fluid embolism. And how do we differentiate them? So once there is maternal cardiopulmonary collapse, which means hypoxia, hypertension, with or without coagulopathy, what we need to do is initially whether there is fever or not. If there is no fever, the patient stands for pulmonary fluid embolism or amniotic fluid embolism. If it is additionally associated with chest pain and dyspnea with clear or unclear lungs on chest X-ray, most of the times clear in the initial phase, it points towards pulmonary embolism because chest pain and dyspnea are not common features of amniotic fluid embolism. Septic shock would be diagnosed if fever and leukocytosis are present. Anaphylaxis would be diagnosed when bronchospasm is present or a previous history of allergy and urticaria is present. Eclampsia, we all know how to diagnose, so hypertension, convulsions, and proteinuria. And myocardial infarction, again a chest pain, and ECG would be showing ST elevation and elevated troponin, which is also classical of MI, not present in amniotic fluid embolism. So the quick tools while we are by the side of the patient could be: is there chest pain, is there fever, is there hypertension, is there convulsions, is there proteinuria, bronchospasm, ST elevation, and is there DIC or not? So presence of DIC goes in favor of amniotic fluid embolism. There are a lot of supportive tests because no test is diagnostic. So full blood count, liver and renal function, electrolytes, and ABG, this would be sent initially and they would help in diagnosis, monitoring, and prognosis. Coagulation studies would further help us in further management. D-dimers would also add in the management portion. Thromboelastography not available everywhere, but if available, it can precisely guide us for which components are to be used. ECG, as I said, to rule out ST elevation, and along with that, to look for the changes in the heart which has occurred because of the cardiovascular collapse. Transthoracic and transesophageal echocardiography would further aid in the in knowing the status of the heart. Chest X-ray would prominently show two things: cardiomegaly and pulmonary edema. And insulin-like growth factor binding protein has recently come up along with alpha-fetoprotein and fetal fibronectin as an aid in the diagnosis of the amniotic fluid embolism, but yet not a very specific marker. There are few other candidates which have been tested as the specific markers for amniotic fluid embolism. This includes zinc coproporphyrin, which is a component of meconium. It has a high specificity, but it needs rapid assay validation, and it is not widely available. Sialyl TN antigen is produced by fetal gut and the respiratory tract. It is also elevated in the condition, but it lacks specificity, so it needs to be combined with other tests. Inflammatory markers are all raised, but they are non-specific. Serum tryptase is produced when the mast cell, the initial reaction and the histamine release. When the mast cell degranulation occurs, the serum tryptase gets elevated, but it has a limited use because its elevation is not very specific. And there are a few others which are also mentioned, but as of now, people are working on zinc coproporphyrin and serum tryptase as possible candidates. The final diagnosis could always be on histopathology. So autopsy plays an important role in the clinical practice, though, as I said earlier, not required for the diagnosis. So pulmonary edema is present in about 70% of the postmortem of these diagnosed cases. It's a very important pathological feature. Microscopic presence of amniotic fluid substances in the lungs, cardiac vessels, and uterine vessels is also an important finding, but it is quite challenging to diagnose because of its minute size. And the histological sections which are taken may not always capture these tiny particles, may lead to under-recognition. Alveolar hemorrhage is a third sign which aids to the diagnosis of pulmonary edema. So the first picture here is a gross picture or a macroscopic picture of the right lung in one of such patient, and the next two pictures are the presence of fetal squams in the pulmonary vasculature. Coming to the last part of the talk, which is management of the patients. The principle of management, the most important principle, is rapid critical care support, along with continuous supportive treatment, delivery of the fetus, and targeted therapy to treat the cause. The goal of the treatment is to correct the cardiovascular and pulmonary instability, and the aim should be systolic blood pressure more than 90, arterial PO2 more than 60, and urine output more than 30 ml per hour, along with achieving good uterine tone and correcting coagulation abnormalities. Now people have come up with a checklist so that in hurry, when we are managing the patient, we are likely to forget few things. So if such checklists are available, some non-medical person can also help us in ensuring that all the things that we need to do have been done or not. So SMFM has developed this checklist, which we can use in our labor rooms in case such situation occurs. So as soon as the patient collapses, we need to activate code blue. And though I understand that most of the labor rooms are not tuned to the coding mechanism, we are entering the era of the modern medicine where we need to develop the habit of coding the different conditions, especially the emergency ones. So code blue signifies a life-threatening medical emergency involving heart or the lungs. Whosoever is nearby the patient immediately activates a code where the patient's name and location are mentioned. And the code can be activated via pager, intercom, or a mobile app. I believe mobile app is the easiest way to activate the code now. The Lakshya assessment, which is a labor room quality assessment conducted across the country in all the government health facilities, also mandates the implementation of code blue. We need to have a team approach. I have mentioned different specialists here, including the senior nurses and the support staff, and everyone has a decisive specific role that one needs to play. So the algorithm of management would be early recognition of the condition with sudden hypoxia, hypertension, and coagulopathy, immediate maternal resuscitation, which would include ABC, oxygenation, intubation, and CPR, hemodynamic support, and the management of coagulopathy. This will continue further to consider the perimortem cesarean section. ICU management and the multi-system support would follow, and the maternal and neonatal survival would depend upon how quickly we have reacted, but there is a risk of long-term neurological injury. I'll go into little depth of the management. I'm aware that few of the parts are not obstetrics, but still. So the management would begin with ABC and obstetric care. Erwin breathing, mostly we need to go with the high flow oxygen 10 liter per minute. Early endotracheal intubation is advisable, and we should not delay ventilation if there are poor responses to the just oxygen management. To ensure circulation, we need to quickly secure two large bore IV lines. If that is not possible, later on interosseous lines may be needed. But we have to remember that this is one condition where restricted crystalloids play a role. So we need to be very guarded as regards giving fluids to the patient throughout the management. Perimortem cesarean section is to be definitely conducted if there is cardiac arrest, but even otherwise, to facilitate the process of resuscitation, we should carry out perimortem cesarean section. It should be done in the labor room only, unless you have a OT which is just 2 or 3 minutes away. With all aseptic precautions and a quick approach. Medical management of hemorrhage, I'm skipping that part because we all know about it, except one thing, that prostaglandin we need to use with caution because it can lead to bronchospasm. And we need to consider the use of tranexamic acid early in the management. Tranexamic acid is even otherwise proving a very good drug for obstetricians. Surgical management, obstetric hysterectomy as a part of initial stabilization may be needed, and it should not be delayed if there is active ongoing bleeding. Then comes the cardiovascular management. There are 4 divisions of cardiovascular management. First is immediate resuscitation phase. So resuscitation for cardiac arrest is done as per ALS guidelines with the displacement of the pregnant uterus towards the left side as shown in this picture. It is said that within 4 minutes, that means within 2 cycles of cardiac compression, if the cardiac output does not return, then in the 5th minute, cesarean section should be performed and resuscitation should be facilitated along with. Epinephrine and norepinephrine follows in the treatment. Epinephrine mainly for cardiac arrest or severe anaphylactoid reaction, and norepinephrine for persistent hypotension. I am not going into explanation of these drugs as generally our anesthetist colleague and physician colleagues take care of this part of management. Right ventricular dysfunction and pulmonary hypertension. This is a stage where monitoring and assessment becomes important. So invasive arterial pressure monitoring and central or pulmonary artery catheter should be done as quickly as possible. And a repeat bedside echo may help in further diagnosing the progression of the condition. Dobutamine is a drug which is useful for right ventricular contractility, so that would become important at this stage. Milrinone is also a good drug for severe right ventricular failure and is available now at most of the centers. And nitric oxide can help in reduction of the pulmonary edema. The right ventricular failure progresses to left ventricular failure, as I have explained earlier, along with myocardial depression and myocardial ischemia. So the drugs need to be titrated when the left ventricular dysfunction is already established. We need to avoid high-dose vasoconstrictor now, but I believe that for this portion of management, the cardiologist must come in the picture to guide us. When there is a refractory shock, vasopressin is the additional drug which can be used along with the earlier catecholamines that I have mentioned. For the cardiac management, advanced management may be needed with ECMO or intra-aortic balloon pump if the facility has that. And I believe these modalities are available at the cardiac centers only, and most of the labor rooms do not have such facilities. Coming to the coagulation abnormalities, we have to manage as we are managing otherwise DIC. So we need to activate the massive transfusion protocol depending on the shock index, which is heart rate to systolic blood pressure. So if it is more than 1.5, if blood loss is more than 1.5 liter, and if ISTH obstetric DIC score is more than 8. The transfusion of blood products would be 1:1:1 of packed red cells, platelets, and fresh frozen plasma. After that, we may add upon individual components depending upon the status of the PT and APTT, the platelet counts, and the hemoglobin levels. Additionally, D-dimers and fibrinogen would help us in deciding whether cryoprecipitate or the fibrinogen concentrates needs to be given or not. And the antifibrinologic agent would support the further management. Factor 7A and factor 10A inhibitors, which is a rivaroxaban, are also useful drugs which we can consider using in the treatment of DIC. And the monitoring would continue with the COEC profile. There is a new development called AOK regime, which is proposed by this group and mentioned in a very recent article in Journal of Perinatal Medicine, which mentions atropine, ondansetron, and ketorolac as a definitive or an etiological management of this condition. They argue that atropine 0.2 milligram IV would mitigate the vagally induced bradycardia. Ondansetron would attenuate the serotonin-induced pulmonary vasoconstriction, and ketorolac would inhibit the thromboxane production, thereby targeting inflammation and platelet activation. So they may act at a root level and may try to reverse the phase 2 and phase 1 of the pathophysiology of the condition. But still, it's an investigational regime and we need to await for further results. The prognosis of the condition. Management of amniotic fluid embolism is a test of ultimate clinical readiness. And clinical readiness is not just a readiness of the doctor, it's a readiness of the entire team. It's a readiness of the setup, it's a readiness of the equipment, and it's a readiness on the part of the entire team. So early recognition, rapid resuscitation, decisive hemodynamic stabilization, and rapid delivery of the fetus is what is going to decide the prognosis of the patient. Maternal mortality I have already mentioned, but 50% of them occurs in the first hour and 66% occurs within first 5 hours, and remaining may die later on, or if they survive, likely to develop neurological sequelae. Fetal outcome also depends on the speed of delivery, and neonate may also suffer the neurological sequelae. So with that, I would conclude by saying that although there are many new developments in the amniotic fluid embolism as a clinical condition, it still continues to be a catastrophic complication of pregnancy requiring a high index of suspicion, a multidisciplinary approach, and a rapid resuscitation efforts in order to have a desirable clinical outcome. So let us all continue to save lives of mothers by being vigilant for amniotic fluid embolism. Thank you very much.
Thank you, Dr. Ashish, for this elaborate talk. You have covered the basics and you've also covered the latest. And I hope we don't encounter such catastrophes, but if encountered, you have given us a very good way of tackling it. Dr. Monica, would you like to add something?
Dr. Monica Batra, are you there?
Okay. Thank you, Ashish.
Thank you,
And
Dr. Rama,
there,
and
she's
thank
there.
you, MC Patel sir, again.
Oh, yes. Pardon?
Thank you, chairpersons, and thank you, Dr. Ashish. That was a wonderful talk, and it was, I mean, you could manage such an exhaustive topic in such a short time, which really shows your expertise. I now hand over the session to the next coordinator, session 3 coordinator, for a talk, for a very, very good talk on medical legal aspects.
Hello. Am I audible now, sir?
Yes.
Yes, Dr. Monica, you're audible.
Yeah. Thank you, chairpersons, and thank you, Ashish sir, for an excellent talk. And now we move on to the third session, which will be by none other than Dr. MC Patel sir. Our chairpersons for today's session, Dr. Sanjay Brahmabhat sir, Dr. Nidhi Vasani ma'am. Sir is an ex-assistant professor at Sri Krishna Medical College and Hospital at Karamsad at Anand. So he's also working as a laparoscopy and gynae surgeon and in oncology in Anand since 2016. He's a visiting laparoscopy surgeon at Parul Sevagram Hospital and Medical Waghodia. Sir also is on panel in the government laparoscopic surgeries in Gujarat state since 21st of November. We welcome you, sir. Dr. Nidhi Vasani madam holds a fellowship in reproductive medicine from CMC Vellore. She is the director and IVF consultant at Sahaj Gastrocare and Surgeon Fertility Center at Bhavnagar in Gujarat. She has 1 international and 2 national publications to her credit. We welcome you, ma'am, as a chairperson. And her third chairperson is Dr. Hitendra Somani, sir. He's the secretary of IFS Gujarat chapter 2024 to 26, the past joint secretary of Indian Fertility Society Gujarat, and the past president of Bhavnagar OBGY Society. He's also the director at Nirmal IVF Test Tube Baby Center and Advanced Laparoscopy Center at Bhavnagar. We welcome you, sir, and I request the chairpersons to introduce the topic and Patel sir today for the next talk, sir. Nidhi ma'am,
Yeah.
are you there? Yes, ma'am.
Yeah, I'm here. Good evening, all. And it's a proud privilege to be here during this talk. I would like to extend my heartfelt thanks to Dr. MC Patel, sir, and the entire organizing committee. And the topic sir has chosen, as usual, is very unique, and he's going to provide us wonderful insights. So POCSO Act is something which we all are, faced with sometimes. And when we are faced with such a dire situation, we do not know how to act. So Sir is going to throw light on a very important and informative subject, because we know that our children nowadays do not live in a very safe environment, and we should know the ins and outs of this law. So to do justice to this topic, we have none other than Dr. MC Patel, whom all have described as the Sankat Mochan Hanuman of obstetrics and gynec people. And we all have his card under our pillow so that we can sleep at peace, as Sir always desires and says. So over to Sanjay sir to introduce Dr. Patel sir.
Hello. Dr. Sanjay sir is not there. Sanjay sir?
Yes, sir, you can introduce the speaker, please.
It's a privilege to introduce Dr. MC Patel, sir. Sir is a stalwart and guiding light for all of us. Sir is a candidate for Foxy President Election 2026. Sir is the most eligible and most deserving candidate for presidency of Foxy. He's worked relentlessly for years together, and he's been always helping to each and every member of our society. This sir has been instrumental in uniform consent formation about the Foxy medico-legal training and support of the member. Sir has been vice president of Foxy, chairperson of ethics and medico-legal committee, organizer of the AICOG 2017, honorary secretary of SOGOG 2022 to 25, and sir has participated in many government activities like PCPNDT, National and State Advisory Committee. Then sir has done a lot of community services concerning Red Cross and also Dhanvantri Seva Yatra. Sir, as a professional leader, sir has always been a leader and helpful to all the gynecologists when it comes to medico-legal problem. Sir has held the post of the President AOGS 2010-11, President of Indian Medical Association 2007 to 8, and Sir has been organizing chairperson of Vivekanand Namukwan. So we welcome you, sir, and please guide us about the much talked about and very difficult situation for gynecologists to handle about the act. Thank you, sir.
Okay. So Please allow me to share my screen. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. And we are going to discuss POXO Act challenges and controversies, dilemma and controversies as far as this act is concerned. So warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the societies who have joined this webinar and president and secretaries of respective society and of course SOGOG office bearer. At the same time, I would like to thank you all because during my election campaign last year, you all stood with me just like a rock. Though I lost, but I believe in this. It is rightly written by श्रद्धेय अटल बिहारी वाजपेयी, क्या हार में क्या जीत में, किंचित नहीं भयभीत में, कर्तव्य के पथ पर जो भी मिला, ये भी सही, वो भी सही. So loss is not the end, but a new beginning, and journey to serve Foxy continued with renewed patience. So my commitment is still there. Wherever you are, I'll be there. Promise to reach the unreached. And though I seeking same blessing, same support, same help. Next year in 2026 election for the same post, President Foxy. So I start usually any of my talk with this question: is it worth discussing? Yes, because as far as this POXO Act is concerned, even today, many of our friends have no clear idea how to act in a given situation as far as POXO's provisions are concerned. So this act was enacted in 2012 and it is specially to protect children from offenses of sexual assault, sexual harassment, pornography, and for establishment of special courts for trial of such offenses and for matters concerned therewith or incidental thereto. And it addresses all the area: sexual harassment, sexual assault, aggravated form of sexual assault, penetrative sexual assault, aggravated form of penetrative sexual assault, and using child as a pornographic purpose. So under this act, any person below age of 18 is child and it addresses both. So it is gender equal. This act addresses both male and female children. So, and we doctors are very important person because we are first point of reference in confirming that child has been or being abused as far as sexual assault are concerned. Say for example, if patient comes with us for any other complaint and once we come to know that she is case of STD and on further interrogation, we may come to know that she is a victim of sexual assault. But before we approach this type of patient in any given situation, very important part is consent. So who can give consent for examination? So can minor girl give consent for examination when she is brought or she has come alone to you for examination and further management? So if she is more than 12, though she is minor, but she is considered as a mature minor and she can give consent for non-invasive procedures. So for simple examination, etc., she can give consent. But can she give consent for surgical intervention or anesthesia? No, because for any invasive procedure, she cannot give consent and consent from guardian is to be taken. Consent should be written, it should be free, voluntary, comprehensive, and informed, and she may refuse before examination or even during examination also. She can withdraw her consent if she is not comfortable. As far as history is concerned, in a very simple words, open-ended, non-leading questions such as what happened, when happened, where happened, how happened, tell me something more, followed by, and then what happened. So our question should be very simple and no uncomfortable question at the time of collecting history. Occurrence of incidents is very much must we have to ask for, whether it was first time or if it is continuous, then when it happened last time is also to be inquired. Time since incidents, any threat given at the incidents, nature of assault, vaginal, anal, oral or others, history of bath after incidents, and history of change of clothes after incidents, because it may differ our findings and investigation. Any complaint of pain, vaginal, anal, bleeding, discharge, we have to inquire. And one more thing, blood in panties or toilet, any difficulty or pain during voiding or defecation, we have to inquire for. And any urinary or fecal incontinence, we have to ask for. Illustrative books, body parts, or doll can be used to elicit the history of assault, because many times small children are brought to us and they do not understand how to answer. So many a time this type of illustrative books or body parts or doll can be taken into help. As far as presence of parents are concerned, if patient is comfortable with their presence, then we have to allow them. But many a time person who has brought the child could be culprit, and patient is not comfortable to be examined in his or her presence. So in this type of situation, we can deny. So patient's willingness is very much important. So we have to ask patient, is she comfortable with guardian at the time of examination? And medical history should cover allergy to some drugs, immunization status, and some medications. As far as examination is concerned, in a sensitive manner, in painless manner, privacy, and least disturbing to child. Using child's word or using drawings for body parts may make child more comfortable, and stop examination if child indicates discomfort or child withdraws permission to continue. Child with physical disability, we have to help child for position for necessary examination. If child resists examination, it is always wise to defer the examination. We cannot insist or force for any examination. And it is very clear, normal or non-specific exam doesn't rule out sexual abuse. One more part, collection of evidence and documentation. Document presence during conversation with the child and document all the questions asked and answer of child. Carefully collect clothing, especially underwear, the most likely positive site for evidence-free DNA and further testing, and preserve forensic evidences. Children often report weeks or months after this abuse event, and it becomes very difficult for examining person to come to conclusion. So whenever you are not sure of your opinion, you cannot give 100% sure opinion, but you can give some possibility with all your explanation. This is why medical providers should always consider differential diagnosis and alternative explanation for physical signs and symptoms. Because many a time there could not be any sexual assault. There could be some other region of injury, but due to some malified intention also, parents or relative may introduce child as a victim of sexual assault. So we should be very careful at the time of collecting history, at the time of examination, collecting evidence, and forming our opinion. Treatment, naturally, we have to treat that very patient. If patient is bleeding or any foreign body inside or so, we have to treat patient accordingly. And if needed, we can go with sedation or even anesthesia also. But for that, consent from guardian is to be taken. Counseling for testing for HIV or any other sexually transmitted disease we have to go for, and we have to offer prophylaxis for STD and HIV. Formation of opinion from our history, examination, collection of evidences, and we have to come to our opinion and we have to report to nearby police station. If juvenile police station is there, then it's fine. Otherwise, local police station or CWC we have to inform, and it is very much mandatory under section 19 subsection 1. And if we fail to inform, then there is a provision under section 21, provision of 6 months of imprisonment. Any person is head of the institution, then imprisonment of 1 year with some fine, and both. Expert evidence in court. Once we have formed opinion, we have given opinion to investigating team, then we are called in court of law for our expert opinion to confirm the diagnosis. So we can give our opinion in court also. But at the same time, let me clear, court is not bound by an expert conclusions and can exercise its discretion in this regard, keeping in mind other evidences only. So court is not at all dependent to come to conclusion only with medical evidence. So they will consider all other circumstantial evidences also to come to judgment. But as far as our practice is concerned, I narrated this act in very brief. But as far as our practice is concerned, we are facing so many situations in our day-to-day practice, and it is related to POCSO Act. So let us see one by one. 16 years old girl is brought by her mother with complaint of vulvovaginitis with discharge per vagina. On examination, it is found to be a case of STD, and she gives history of sexual exposure with her boyfriend on further interrogation. What will you do in this type of situation? Naturally, we have to treat patient because patient is brought to us for treatment of vaginal discharge. And when it is found that she is case of STD, of course we have to treat. But at the same time, we have to inform police because she is 16 years and it becomes a case of POCSO, and we have to inform police. Sorry, something went wrong. So let us see one more situation. 17 years old girl with mother visit hospital with 6 weeks pregnancy for termination of pregnancy. Doctor explains that I will do termination of pregnancy, but as per law I will have to inform police. So in this situation, patient and mother refuses for the same and leave the hospital without taking any treatment further. What will you do? In this situation, even if patient takes further treatment with you or not, but once you came to know she was minor, she is a victim of sexual assault because she was having 6-week pregnancy, you have to inform police. Let us see one more situation. 17 years old girl comes with her boyfriend. She asks for contraceptive advice. Many a time this situation may occur. Girl and boy comes to you and they will say, we are going to start our active sexual life and we do not want any unwanted pregnancy. So please guide us as far as contraceptive measures are concerned. So what will you do in this type of situation? Can you advise? Will you advise? Because on one side, it is a moral duty. Why? Because if do not advise, and if they have decided to go with active sexual life, they may end up into unwanted pregnancy, and ultimately they will come to us only for termination of pregnancy. But on other side, as far as law part is concerned, it becomes a case of abatement because you are encouraging them to constitute crime because both are minor. Even if boyfriend is major, but when girl is minor, it becomes a case of POCSO if at all they go with sexual active participation. So if we advise them, then it is interpreted by investigating officer that you instigated them, you helped them to constitute crime. So of course you can give them health education, but you cannot prescribe any contraceptive measure, and we should be very clear in this type of situation. Let us see one more situation. 18 years, 6-month-old married girl brought by her mother with pregnancy of 39 weeks and siege for cesarean section. Siege major, 18 years, 6 months, but 39 weeks of pregnancy. What will you do? Naturally, we have to proceed for cesarean section if it is indicated, but we have to inform police because at the time of conception, she was minor and it becomes a case of POXO. Let us see one more situation. And this is real happened case in our South Gujarat with one of our gynecologists. Patient gives history of 20 years of age, primary, 8 weeks pregnancy, willing for termination, and pregnancy was terminated. Because her center was registered, our gynecologist friend was qualified. So pregnancy was terminated. After 1 month, police comes. She was 17 years and under POXO Act, you were under obligation to inform. Why you didn't inform police? So in this type of situation, very important question, who is responsible to determine the age? Naturally, doctor. Because in Supreme Court, they are very clear. You will have to determine age if at all you are in doubt. So you can ask for ID proof, schooling certificate, election card, Aadhaar card, driving license, and you can subject patient for clinical examination, dental examination, radiological examination, or you can ask through police, forensic medicine department's opinion as far as age is concerned. If, whenever you are in little doubt that patient could be minor and see is a case of sexual assault, you can ask police that I am not sure of age, but these are the symptoms. So please help me or guide me to come to conclusion as far as her age is concerned. So you can go like this also. How to inform? Inform with acknowledgement, because many a time police may go hostile. You didn't inform. So you have to inform with acknowledgement. So what to do in this type of situation when police is not complying to give acknowledgement? You can dial 100, it is recorded call. But in this situation, identify the person whom you are informing with his name, buckle number, date and time, and record it. So you can ask that I had informed Mr. So-and-so at this point of time on this date. By registry ID, you can send the same information by registry ID post, or you can send it by mail or telephone with recording. If your facility in your mobile or any other telephone as far as recording concerned, you can give information on telephone also. But again, you identify the person whom you are giving information. Inform higher officer. If lower officer is not complying, then you can inform higher officer also, or you can inform CWC, that is Child Welfare Committee. And once you inform Child Welfare Committee, your job is over. One more situation. Can doctor refuse to examine victim of sexual assault who come to hospital for treatment, citing that it's a MLC case and require police requisition or magistrate order? No, this type of order or police request is not at all required, and you cannot deny merely on this ground. This is given in POXO Act also. Let us see. Before that, voluntary reporting to a hospital or to the doctor is a legal right of victim of sexual offenses, and you are under obligation to examine and treat them in that given situation. Let us see one more situation. 17 years old girl visit a private hospital with history of sexual assault. Doctor asked her to go to government hospital as it is a MLC case and has to be examined by government doctor only. Is it mandatory that victim of sexual assault has to be examined at government hospital only? No, it is not like that. It is mandatory to all hospital, irrespective of being government, public or private sector, to provide immediate medical care and treatment to victim free of cost. Till patient becomes stable, you have to treat that very patient totally free of cost, and then after you can ask patient whether she is comfortable to continue treatment with you. Then after you can charge. But to stabilize her, you cannot charge. And if patient is willing to go somewhere else, then you can refer patient to another hospital. Let us see one more situation. Is it necessary for a female doctor only to examine sexual violence victim, because many a time this is interpreted by this CRPC section 53 subsection 2 mandates that if arrested person is a woman, her medical examination must be conducted by or under the supervision of female doctor. But it was for accused. When female is accused and she is arrested and some examination is needed, then it was mentioned in CRPC. But many a time, insisted sexual violence victim to be examined only by female doctor whenever available. If female doctor is available, it is to be preferred, but it is not at all mandatory. If patient is bleeding, if patient has severe pain, and no female doctor is available, should we leave that patient to mercy of female doctor to come, or should we refer that very patient to nearby hospital to have female attendant? No, we can very well attend that very patient in given situation, because in eye of law it is very clear, whatever you do in good faith of patient is always pardoned. So criminal law amendment in section 164 subsection A, it is very specifically mentioned that specific law for medical examination of a rape victim, it mandates that a victim be sent to a registered medical practitioner for examination within 24 hours of complaint. Here simply registered medical practitioner word is used not. It is not specified that female registered medical practitioner. So it is mentioned in section 164A of CRPC. So it is very clear, any doctor with whom a female victim consented can carry out the examination. If patient has given a consent to be examined, to be treated by a male doctor, then male doctor can also attend that very case. Let's see one more situation. 17-year girl in relationship with her boyfriend, when she failed to have her menses on regular due date, she got anxious and visited her doctor. She disclosed that she had relation with her boyfriend very regularly. So she was worried about her conservative parents, and she was willing for termination of pregnancy. But in this situation, important question to doctor, whether to inform police? Always yes, because it is very much mandatory. Whether to inform girl's parents against her wishes. So if patient is not willing to inform her parents, you cannot inform. If patient is more than 12 years, because she is mature minor, she can take decision. If she can give permission or consent for examination, at the same time she can take decision whether parents are to be informed or not. And we cannot inform parents against her will. And if at all we inform, and if she goes in court of law against us, then it becomes very difficult for us to face the situation. So we should be very careful. Let us see one more situation. 16 years old girl, victim of sexual assault, was brought to your hospital for treatment. Mother insists on you to conduct medical examination, but victim doesn't want examination. Just I mentioned prior also, if she is more than 12 and if she is not giving consent, you cannot force her to examine. Even if her relatives are insisting for examination, you cannot. So one more situation. 17 years old girl had eloped with her boyfriend and became pregnant with 16-week pregnancy and requested for termination of pregnancy. She is not willing to revert her boyfriend's name and requesting not to inform police. So what to do in this situation? We have to inform police because it is very much mandatory. But patient is minor. So as far as termination of pregnancy is concerned, some guardian who is major should give consent. In this particular case, her father was not ready to give consent. So in this situation, what should doctor do? Whose consent can be taken? MTP is an invasive procedure, and consent more than 18 years of age is very much required. Consent of mother can be taken in this situation, but many a time when father has refused, mother cannot dare in this situation to give consent. So in this situation, if it is in government hospital, then medical superintendent, RMO, CMO, head of the unit, head of the department, can also give consent in good faith of patient as a guardian. Inform Child Welfare Committee. If you inform Child Welfare Committee, any person from Child Welfare Committee can also give consent, and you can very well terminate that very pregnancy. But at the same time, word of caution, you will preserve product of conception in normal saline and you will hand it over to the police. But in this case, again, when a father had given consent for termination of pregnancy, he insisted to send product of conception to police, and patient was not willing to send product of conception to police because he was not interested to reveal name of her boyfriend. So in this situation, what doctor should do? So argument on part of father was he had given consent for termination of pregnancy, so he has right to decide. And argument on part of girl was she is more than 12, she can take decision. And in this situation, of course, you can note in your case paper that patient has refused, there is negative consent, and have a signature of patient and signature of guardian that before guardian patient has signed this document. And in this situation, of course, you cannot force, but you can explain what is the importance of examining this material to be sent for further investigation. But in spite of all this, if patient is not willing, you cannot force. So what if gestational age is more than 24 weeks in this type of situation? Who's consent for it? So in this situation, you will have to ask for opinion from medical board. And if fetus is having congenital fetal malformation which are incompatible with life of fetus, then only medical board will opine to terminate pregnancy. In all other situations, when pregnancy is very normal, even if she is rape victim or victim of sexual assault, unless there is opinion from medical board, you cannot terminate. But in normal pregnancy, medical board has no power to opine. So in this situation, you will have to prefer writ petition before Honorable High Court to terminate pregnancy. Let us see one more case and we will conclude. 16-year-old girl brought with alleged history of sexual assault by one of her family member. On examination, no physical or genital injury and no evidence of spermatozoa were found. What should be your opinion? Can we give provisional opinion? So we can give provisional opinion like this. Either victim is used to an act like that of sexual intercourse. Opinion 2, an act of sexual assault neither be confirmed nor be refused. And opinion 3, no evidence suggestive of sexual intercourse. So whenever you are not sure of your opinion, you have not to give opinion that she is victim of sexual assault. You can very well give your guarded opinion, and you can advise police for further investigation with forensic medicine department in nearby medical college also. Let us see one more situation and we will conclude. 15-year-old girl sexual assault victim approached government hospital for MTP. Mother requested doctor not to inform police and settle the matter between them. Doctor asked them to come to private clinic. This has happened in state where private practice is allowed to doctor who are working in government hospital after their working hours. So doctor advised mother that better you come to my private in evening, and so we can avoid mandatory reporting, etc. So question here is doctor right in this decision? No. Even if you are dealing that patient further in your private hospital, but once you came to know that she is pregnant, she is minor, she becomes a case of POXO, and you are under obligation to inform police. So to conclude, a responsible medical professional is under obligation to report to appropriate authority about any child of sexual abuse he comes to know during his professional medical study. And he has not only to examine and treat, but he has to form opinion whether sexual abuse has happened. And he is a very important person to be helpful as an expert witness to prove a crime of sexual child abuse. So comply with law of land and be vigilant in your practice. Otherwise, be ready to face this type of situation in our practice. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. So have some basic legal knowledge and always obtain medical legal advice whenever you are in doubt. So take medical legal advice whenever you are in little doubt from point 1, because once you submit any document to anybody, then you cannot change it. So to conclude, if you want to sleep like this, take tender care of your patient, comply with the provisions of POXO Act, pray Almighty God before going to sleep, and keep my visiting card below your pillow, because I am always there to assist you in any given situation. So God bless you. Have a litigation-free medical practice. With regards and with my humble appeal, please endorse my candidature for the post of President Foxy election year 2026. So salute to all the societies and all the president and secretary of respective society. Thank you very much. Please do not assume. Please ask if any query, any question, if time and chairpersons permit. Thank you very much.
Thank
Thank
you,
you,
sir,
sir.
for that outstanding presentation. It was very concise and yet very insightful at the same time. So it has left a lasting impression. And after the routine PCPNDT Act, we are now aware of this new POXO Act, and I think we can put it into a practice whenever required as the case scenario arises. So thank you so much. And we know at the end of the day, we have got you. So you have our back.
Thank you, sir. Thank you. We all understood one thing, that follow the rule of the land and always do what is right, take advice. And many times we fall into tricky situations, but important is to do right and do lawfully and take advice of senior person like you. Thank you so much, sir.
Thank you.
Thank you, MC sir. Excellent talk as always. Thank you, Nidhi ma'am and Hitendra sir for being there throughout. We will now move on to the next session. We have a very interesting panel discussion coming up. It's a panel discussion on labor room emergencies, case scenarios in labor room emergencies. It's a very good pool of panelists that we have. The session is going to be moderated by Dr. Nitin sir and Dr. Sonali ma'am. And the experts for the session are Dr. Jagdish sir and Dr. Archana Dwivedi ma'am. Can I have the slides? Yeah. Dr. Nitin sir is professor and head of department at PSMC Bhaikala University at Karamsad, Anand. He's also a PG and PhD guide and a master trainer for emergency obstetrics. Welcome, Nitin sir. Our next moderator is Dr. Sonali Agarwal ma'am. Ma'am is associate professor at Medical College in Baroda, and her fields of interest are reproductive endocrinology and high-risk obstetrics. Waiting to listen to you, ma'am. Welcome. Our experts for the day are Dr. Jagdish sir. Sir is the Joint Secretary of SOGOG, organizing co-chairperson of SOGOG 2019. He is the Dean of PIMSAR, Parul Institute of Medical Science and Research at Vadodara. Welcome, sir. Our next expert is Dr. Archana Dwivedi ma'am. Ma'am is the national chairperson for the IMS website committee between 2023 to 2025. Also has been the president of BOGS as well as the president of MSV, secretary of women's wing of the IMA, and has been practicing since the past 20 years. Welcome, ma'am. We have a very interesting lineup of panelists with us. Our first panelist is Dr. S.P. Patel, sir. Can I have the CVs? Yeah. Dr. Sunil Patel, sir, is the ex-secretary of the Obs-Gynae Society of Godhra, as well as the ex-state VP and the ex-president IMA of Lunawada. Welcome, sir. Our next panelist is Dr. Jaina Shah, ma'am. Ma'am has 37 years of wide experience as a practicing gynecologist. She's trained in ART as well as advanced sonography and advanced laparoscopic surgery. Welcome, ma'am. Our next panelist is Dr. Maitri Patel. Ma'am is a consultant in Obs-Gynae at Spandan Hospital, Anand. Also an ex-professor of Pramukh Swami Medical College, Karamsad, and a life member of Indian Menopause Society. Has been the secretary of Anand Obs-Gynae Society. Welcome, ma'am. Our next panelist is Dr. Sujat Wali, sir. Sir is a consultant at Lara Mother Healthcare and IVF Centers. Sir has been known to be conducting various educational activities and also has been awarded with medical excellence in 2013. Welcome, sir. Next panelist is Dr. Pinky Kataria, ma'am. Ma'am is the director of Radhaswamy Multi-Speciality Hospital and IVF Center at Nadiad, Gujarat. Also an active member of Foxy Endocrine Committee. Welcome, ma'am. Our next panelist is Dr. Binal Shah. Ma'am is the Joint Secretary of the Indian Menopause Society, consultant gynecologist and laparoscopic surgeon at Vadodara, Gujarat. Also the Foxy representative from BOGS and convener of the IMS Wellness Weekend Series. Welcome, Binal, ma'am.
Yeah, thank you.
Our next panelist is Dr. Snehal, ma'am. Ma'am is the medical director and consultant obs-gynae specialist at BIMS Multi-Speciality Hospital, Bhavnagar, and also the president of the Bhavnagar Obs-gynae Society. Welcome, ma'am. Our next panelist is Dr. Ranjit Chaudhary. Sir is the ex-president and secretary of the Bhavnagar Gynae Society and organizing secretary of SOGOG 2010. Welcome, sir. Our next panelist is Dr. Dolly Ramnani. Ma'am is a medical director at Aniba Pediatric Orthopedic and Women's Hospital, an honorary professor at Parul Institute of Medical Science and Research, and is a consultant at Kashiba Govardhan Das Patel Children's Hospital. Welcome, ma'am. Our next panelist is Dr. Jignesh, sir. Sir is a consultant at Geeta Maternity and Nursing Home, 3D, 4D sonography and laparoscopy center at Ahmedabad. He also has the Ian Donald diploma in sonography as well as trained for fetal echo and color Doppler. Welcome, sir. I think over to Nitin sir and Sonali ma'am. Looking forward to an excellent panel.
Yes, thank you so much. Yeah, Nitin, start the introduction.
Yes, Sonali, start it.
Okay, thank you so much for all the kind words. Respected experts and dear panelists, we hope to have a very insightful panel. The session began with very interesting lectures by Dr. Deepa, Dr. Ashish, and Sir himself. So we are looking forward for an active participation. I know that with the very good panelists around, our jobs is just to ask questions and the rest will be done by the panelists and if anything left by the experts, Dr. Archana and Gohil sir. May I please request Mehul to start the presentation? As it's a combined presentation between me and Nitin, we have shared it with him. So I request Dr. Nitin to begin the first case.
Yes, ma'am.
Dr. Nitin, could you just begin the first case?
Okay. So we have not shared any cases to any of the panel members. It is just real cases what we had received in last few months as a part, and sometimes many of these cases all of you might have also got. But it's a good to have a discussion as a part, and there are different viewpoints we can think of as a part. So it's a 25-year-old female working as a housewife residing at Mogar. She is a Gravida 2, abortion 1 with 33 weeks of pregnancy, referred our hospital in view of IUFD with HELP syndrome. She had complained of lower abdominal pain since few hours and fever and fatigue since 10 to 12 days. She was advised admission for further evaluation and management, but she was taking her routine ANC visit at outside and was taken 2 doses of injection TT in the currently on tablet iron and calcium.
Next slide.
Patient was conscious, well-oriented to time, place, and person, moderately built and fairly nourished. Peripheral examinations were warm. Temperature was normal, but the pulse was 128 per minute. Blood pressure 134/70 per minute. SpO2 was normal. Urine albumin was +2. RBS was 59. The edema was plus. Icterus was plus. CNS patient was conscious. The respiratory chest was clear. Cardiac was normal, and the obstetric examination shows 30 to 34 weeks. Cephalic, FHS absent, uterus relaxed, mild white discharge. External os 2 finger, internal os 1 finger, cervix uneffaced, privy vortex, membrane present, pelvis adequate. And local examination, no active bleeding. So now I would like to ask the panelist, what do you think it could be? Any of the panelists can take a call.
Good evening, Nitin bhai.
Good evening.
Maitri here. Hello. According to the slides and what you have explained, on ultrasound, was it a fresh IUD or it is the signs of old IUFD?
Fresh IUD.
Fresh IUD. So it was already diagnosed as HELP, referred as HELP only, or it was diagnosis
So refer
by
sheet,
the...
refer sheet was mentioning HELP.
Okay. So most probably, and what about the coagulation parameters?
We'll send the investigation. So
Okay.
what are the investigation would like to send in this such case?
Okay. So as it was a fresh IUFD and the patient is already having icterus plus, so jaundice maybe further investigation definitely require for the identification. We can't label just on paper that it is the HELP patient. We need to have certain investigation for the proof that this is a case of HELP. We need certain documentation in the form of whether we should go for further. Was a case of first abortion and second gravida, right?
Yeah.
So urgent delivery is recommended in such cases.
Okay.
And but the investigation reports will guide you more that we should take her for IUFD and C-section as
So
not much
what else is there in your mind apart from HELP?
Acute fatty liver of the,
Acute fatty liver,
sir, I'm Dr. Pinky Kataria.
AFLP.
Yes, ma'am.
Acute fatty liver we can suspect as the clinical examination suggestive of the icterus phase, and definitely a complete liver function test and complete RFT with all the bleeding parameter has to be done, as this is almost near term pregnancy has been seen as a intrauterine fetal death, and it might be supposed to be a fresh, but previous sonography like Doppler or even early sonography, if scan has been, patient is taking repeatedly, antenatal visit has been done, and we can follow that whether she is having a post, I mean, that is actually a FGR and IUFD has been occurred or not. We can have some idea about the previous antenatal visit, patient is having a hypertension or not. And from all the investigation, we have to come to the diagnosis most probably. And of course, if it is a icterus, we have to go for the liver sonography too, whether it is a cholestasis of the jaundice and some of the other causes of the icterus also, surgical icterus also.
Okay.
May be related with a clear-cut infective cause, hepatitis A, hepatitis B, which can also be ruled out by the investigation profile.
Okay. Any other panelists want to add anything?
Can we have a lab parameters, sir?
Okay, let's see. So from the clinical diagnosis of differential diagnosis of abruption, HELP syndrome, jaundice or infected jaundice, some part was there. So can I have next slide? So these are the investigations. So peripheral smear shows anisopoikilocytosis, hemoglobin was 12.7, platelet count was 63, was not actually documented on that part. Manually, they suggest around 80,000. And her PT more than 60, INR was more than 5, APTT was more than 120, fibrinogen less than 70, D-dimer 9,500 plus. And other reports, liver function test, sodium and potassium were normal, and bilirubin was around 21, direct was 14, indirect was 6, and SGPT was 66, SGOT 179, create was 2.5, thyroid hormone was 0.4, LDH was 1027, CRP was 22, and dengue was negative, fewer other profiles were negative. other HAV, HEV were negative.
Yes, here we can see the high alkaline phosphatase level, which also suggestive of the blockage of some biliary tracts and all, or maybe some acute some liver disease. So we need to go for the liver sonography, and definitely liver has a
Liver has
source
a
of
hepatomegaly was there.
yeah, hepatomegaly. And what about the gallbladder and CVD, sir?
They were normal.
Were normal.
Yeah.
Okay. So this would be, I would suggest, that is a definitely fatty liver, acute fatty liver with some of the changes because of the liver is affected, and IUFD both can cause a high level of renal also there is affected. Yeah. So what is the renal sonography, sir? Serum creatinine is also sign.
Mild change in the corticomedullary differentiation, but otherwise normal.
Okay.
Right. So, any other panelists want to say anything? Snail Ben?
Very
All
obvious
the diagnosis.
liver function abnormality. It is abnormality in the renal function, IUFD, jaundice. All are in favor of the HELP syndrome. Yes, or acute fatty liver of pregnancy. So as she rightly mentioned, that these are the parameters which can help to conclude a diagnosis.
So all the panelists are right in the beginning. So the clinical feature of vomiting, abdominal pain, and polyuria, encephalopathy can be there. So 6 out of 14 criteria of the Swan's criteria are diagnostic because they are overlapping. So many things are overlapping for the infective hepatitis versus HELP syndrome versus sepsis and acute fatty liver of pregnancy. So bilirubin more than 14, leukocytosis, uric acid is more, creatinine is more, ammonia, hypoglycemia. So if you had seen the first slide, RBS was 56 in the clinical part. So that was also one indicative point, and coagulopathy is rightly there as a part. Bright liver, ascites, and hepatic microvascular steatosis was a part of this if we do the biopsy. So these are the criteria are there. So out of this, it was a diagnosis of fatty liver of pregnancy. How we should be managing this patient? So whether our friend has sent this patient rightly to us, or he could manage it his place also.
Definitely, it is institutional care required to such patients.
Yes. As all the blood bleeding parameters are altered, it should be taken at the level where the lots of whatever the coagulopathy missing, like whether it is missing, there is a any deficiency of platelet, definitely a platelet deficiency. There might be some coagulation factor also deficiency because the liver is affected there. And we have to treat all these according to the criteria as mentioned earlier by I think Dr. Ashish Shah and definitely we have to treat their under the critical care parameters as soon as fast delivery, because acute fatty liver changes will definitely disappear soon after the definitely soon after the some of the criteria. It is a reversible effect of the pregnancy, and once it is been delivered, we can assure that patient can be survived. But this is the definitely case of third. Where all the blood parameters, blood products are available widely, and under critical care person is always taking care for at least round the clock, and all the parameters to be done at lab parameters, and fastest delivery to be done with all teamwork basically to be done. So
multidisciplinary approach should be there. There has to be an ICU because if the patient goes in for DIC, as the picture shows, during delivery or after, and it would require many physician, ICU specialist, critical care specialist, and everyone has to be involved with a good amount of blood and platelets and whatever is required. So it has to be an institution with
next slide, please.
ICU facilities.
Yes. So key, all of you has rightly mentioned, the direct bilirubin is increase, transaminases are increased, iron are more than 1.5, platelets are low, glucose is down, uric acid is disproportionate. So these are the classical part of the acute fatty liver pregnancy, while absence of hemolysis, which is classical on the peripheral smear part. So always whenever we send for the CBC in our obstetric patients, particularly anemia is there, blood loss is there, or any part is there, please request your laboratory to prepare a smear. Many a times this peripheral smear gives us an idea about the hemolysis, and that can be simply differentiate that it is not HELLP, but something else is there as a part. So it will differentiate directly from HELLP syndrome to the AFLP as a part, or any other causes of DIC if you want to look at part. So peripheral smear, we should not, our basic thing part is there, and we should always insist on this. It will give us a lot of part. And as Ashish was mentioning, there is a elastography, thromboelastography is a very again useful tool to tailor-made the requirement of the components. So even with the minimal components, we can take care of the best output, because the balance is important, because our ICU friend critical care intensives are very much worried about the trolley and fluid overload, and issues are there. So how to balance with the number of products, because this particular patient has received around 68 components overall, if we can say as a part. Next slide. So as I mentioned, imaging is a very much role to help us differentiate. And biopsy is optional. So in altered parameter, anyway, we are not going to do biopsy at that point of time. So that we are not doing. Next slide. The next. So already all this as we have discussed, HELLP and AFLP, that is a hypoglycemia, coagulopathy, encephalopathy is less frequent with the HELLP, and hemolysis is again classical important aspect. Next slide. Other viral hepatitis, drug toxicity, but Chiari and sepsis. So all the panelists has given this emphasis on this, how we can differentiate between the viral hepatitis, that is infective components. Drug toxicity many times we miss, so we have to just keep in mind as one of the differential diagnosis for the jaundice. So whenever a patient of jaundice, in our detailed history, medication history should be there as an appropriate aspect. And imaging will always help us for the obstructive causes as a part. Next. So case 2. Shalini ma'am.
Okay. Yeah. So taking over the case, thank you, Dr. Nitin. It was very good discussion. Between me and Dr. Nitin, we have just put Dr. Nitin is going to take very, very rare cases of emergency in the labor room, while I am going to take more commoner cases. The name of the panelists I have written on the slides. However, anybody is open to take the questions. So this was a case of Mrs. XYZ, 34 weeks. She presented to labor room with 6 to 8 hours of rupture of membrane while she was in labor for 6 to 8 hours, and the rupture of membranes occur while she was just coming to the hospital. She was a gravida 6 para 5, that's a grand multipara, had a high floating head on abdominal examination. The fetal heart sounds when seen was severe bradycardia. On pervaginal examination, it was 8 to 9 centimeter dilated. The membranes absent, presenting part was not palpable, and the umbilical cord was present. Next slide. So what is the diagnosis and what are the risk factors? I have written the name of the panelists, Dr. Sujat, Dr. Pinky, but anybody can answer if wished.
Seems like a case of quad prolapse.
Yes, very true, Dr. Snehal.
So it could be a transverse lie with a cord prolapse, and grand multipara being laxity of abdomen and a preterm patient with a rupture of membrane. So that could have led to this cord prolapse.
Yes, very well put. Next slide. So these are the common predisposing factors: mild presentations, polyhydramnios, prematurity, grand multipara, and rupture of membranes when the presenting part is not engaged are one of the most common predisposing, or you could say, the risk factors. Next slide. So now we've diagnosed that it's a case of cord prolapse. Comes the next question: what is going to be our plan of action? Anybody can take. Dr. Patel, Dr. Maitri, Jaina madam, anybody. Yes, Maitri.
Yes. we examine such patients and when we feel that cord is already as a presenting part and there is no membrane, you should not leave your hand from the vagina.
Yes.
Inside vagina, shift immediately or level or in medical colleges, there are already labor rooms and emergency OTs are there in the trauma scene. Shift immediately patient for C-section. And as you mentioned that fetal bradycardia is there. So for the same, you can go for immediate C-section as it was a malpresentation, bradycardia and cord prolapse. So again, a clear-cut case for emergency.
Yes. Dr. Jaina, Dr. Sunil, do you want to add up anything?
So mainly, I just want to add one thing that,
Yes.
when putting hand in the vagina, our purpose is not to keep palpating the cord or kind of, feeling the pulsations or, I mean, don't manipulate the cord at all. Main purpose of putting the hand, keeping the hand in is that we are supposed to avoid the pressure of the head or any other presenting part on the cord.
Yes, exactly.
So when
Yes.
our hand is there inside, we should be kind of, trying to push if something is kind of pressing on the cord and not try to keep palpating the cord or anything. So
Perfect,
I just want to
Very
clarify.
You can lift your
very well
legs
put.
a little bit so that
Maybe a head low position
presenting
also
part
could
just go away from the cord and there is no pressure on the cord.
Exactly. Preventing the pressure on the presenting part and avoiding the further bradycardia by stimulation of the cord because it leads to vagal activation and further bradycardia should be avoided. Filling of the bladder and a head low position would help in the presenting part to still go upwards and emergency surgery. Next slide. So these are what the thing should be done or the sequence of actions should be done. It is an emergency, so you would need a team approach. So call for help. Maternal positioning. There have been studies saying that a steep Trendelenburg or even a knee chest position, like the woman coming in a knee chest position, there are evidence-based guidelines that knee chest positions would further push away the presenting part and how much awkward it may sound for the patient or for the people who are telling this knee chest position is a real savior. And then monitoring continuous and deciding the role. The termination is very, very important. Next slide. So the $1 million question, is there any role of vaginal delivery or a cesarean section is mandatory? What is the panelist take on this?
C-section is mandatory unless we have palpated the cord in a very early stage and it can be moved and the presenting part can be felt and it is coming down instead of the cord.
See, what
But
if it is
immediately we can decide whether it is going to happen or not. Otherwise, we should not keep on manipulating.
very true, but a situation where you may need another 10 to 15 minutes to operate, which is in most of the times. So still would you do it, or if it is just a impending delivery, can you give a trial of labor?
Till we have everything ready for LSCS.
Straight away C-section is required because
Section would be
FH
required,
is-
but until everybody comes and
If she delivers, then it's her problem.
it's fully dilated.
Sometimes miracle happen, but yes, we should not
Yes,
wait
yes.
because we should start our
Otherwise,
steps
the
for
cord
the
would not have
C-section.
come down if the presenting part was so.
Very
Usually
true.
they don't.
Next slide. Yes, so immediate cesarean section is needed most of the times. However, if it's a fully dilated with a low station and impending delivery is there, then even delivering vaginally is the option. You are medico-legally immune against a vaginal delivery because there have been reports and the fetal outcomes are not as bad. So even if a vaginal delivery occurs, it is fine. Next slide. So now you are taking up the patient for a cesarean section. Any particular things to remember while you are doing the operation? Like what the intraoperative care in cases you are operating for a cord prolapse?
Ranjit sir.
Dr. Ranjit, Dr. Jignesh, Dr. Dolly, any of them? Okay, fine. The panelists who are available.
Yeah, so basically she's a case of grand multipara.
Yes.
And it's an probably a abnormal lie. So at the time of delivery, you will have to be careful of where you are putting the incision, because you might need to put it slightly higher up. And then intraoperatively, you might have to do a podalic version and deliver by breech, or, you'll have to, take that call on table.
Very
And
true.
plus, at the same time, obviously the pediatrician has to be definitely there to resuscitate the baby. Plus, you have to be careful about the postpartum hemorrhage or even intrapartum, because it's a grand multipara, and so the risk of atonic is always there. So you have to be prepared for that as well.
So this is the beauty of having very expert panelists. The moderators hardly have to bother to do anything. Most of the answers come from the panelists, and very true. The next slide. This what all Dr. Beenal has already elaborated. The OT preparation, incision planning, and the neonatal coordination are the things that have to be remembered. Next slide. Yes, the third case, Dr. Nitin.
Before we move ahead, just I would like to have comments from Jagdish sir. Our experts are there.
Yeah, thank you, sir. I would like to congratulate you on the part that peripheral smear is very, very essential, because sometimes there are overlapping of things like PTP, HELLP syndrome. So that was very good take-home message. And I think cord prolapse, Sonali has made it very simplified. The diagram itself is, and I think this is one of the nightmares we wish not to happen. So I think we have a worthy panelist getting the answers very crisp and right. I'm actually enjoying the discussion. If Goyal sir would add something to it, I don't know.
Sir is there?
I cannot see him.
Sir's name is not seen on the participants.
So we can go ahead with the
Yes,
third case.
sir, you can go with the third case.
So 25-year-old female working as a housewife resident at Khambat referred to emergency in view of known case of bronchial asthma and query community acquired pneumonia. She is gravid 2, para 1, 28 weeks pregnancy with previous 1 normal vaginal delivery, presented with chief complaints of severe breathlessness on rest since past few hours and breathlessness with the minimal exertion since 3 days. So she was advised admission for further evaluation and management. So past history of known case of bronchial asthma since 5 to 6 years on medications, and past history of hospitalization of 25th February, so I think 10 days back, for fungal pneumonia with hemoptysis with left-sided pleural effusion. Pleural tapping and bronchoscopy guided BAL was done at that time, and was a history of recent hospitalization of 2 days of acute exacerbation of asthma. And allergy to the smoke and dust was also present. Next. So when we examine the patient with this history background, temperature was normal, pulse was 140, BP 114/60, and oxygen saturation was 85, FiO2 and VCSE mode, and respiratory rate was 26. So what do you say? What should be the problem here and how we should go ahead? Again, it's open to all the panelists. I'm not able to see any other. Jaina ma'am is there?
Yes, this is a clear-cut case, as you said, that it is acute exacerbation of bronchial asthma along with pneumonia. So we having as you mentioned.
We are not getting, Maitri ma'am, your voice is not clear.
There's possibly an internet issue at her side.
Internet issues, I think so. Yes. Any other
So
panelists
first,
can take.
So mainly she is disoriented because of the hypoxia. So
Yes.
we need to correct that, and just supplementing oxygen was not going to help because of the spasm which is there because of the asthma. So we need to give nebulizer and drug along with the nebulization, so that there is bronchodilation and the oxygen would reach and oxygenation would be there. So
Okay.
first thing needs to be taken care is about the improving her oxygenation by giving her nebulization.
Okay.
Yeah.
Already that incubation was done and the VCSE mode started, but still
Right.
SP was 85%.
Okay. Even okay. So
Okay.
then we have
Basically,
to.
she needs nebulization, steroid hydrocodone and duolin budate nebulization. She needs steroid hydrocodone for as a part of treatment for the asthma, and for pneumonia you require to switch over for the higher injectable antibiotics. Admission in definitely ICU care required in such cases.
Okay.
Like sir, you are trying to. In
Uh-huh.
spite of intubation, if the oxygenation is not improving, then we need to check the lungs. I mean, if there is any collapse or anything. So
Very
that
important.
yeah,
Yes,
and
yes.
there has been a recent intervention also. You said that there was that
Yeah.
lavage which was given and all. So basically, we need to first rule out that with the imaging and all.
So along with imaging, basic blood investigation, any other specific investigation would like panelists want to add?
Arterial blood gases, ABG.
Yes, ABG very important. It will showing the acidosis.
X-ray chest with shield maybe.
Yeah, that
Yes,
that's already said, na? Imaging. I said, huh.
Imaging Madam tool. Apart from this, should we think of
Stabilizing
Cardiac
CT,
also
HRCT chest?
yes, for what purpose?
After stabilizing HRCT chest for ruling out the infection part and the lung which gets compromised, the function of that.
Okay.
Pulmonary
Yes, so,
embolism can
as
be
Ashwin
ruled
Bhai was
out.
mentioning, can it be acute exacerbation? Is it embolism? Anyone?
Yeah, it could be embolism.
Could be embolism. So you have to check for the cardiac status, 2D echocardiography, CTPE.
Whenever
CTPE,
there's so
sorry.
much SpO2 not being maintained along with lung problem, I think cardiac always has to be ruled out because of it, which may be something which may have been missed and
Yes,
exacerbated.
Nivita is mentioning
the second
inpatient-perfusion
trimester of
ratio.
pregnancy.
Okay. Good. So, confusions are there and echo has to be there. Next slide. So, just adding on that while going on, this is a 28-week size, FHS regular, uterus relaxed, patient was not in labor. Next. So, these are the blood parameters where they're available. Total count was 6,000, hemoglobin 10.1, prothrombin time was 1.1, INR normal, APTT was normal.
Senior doctor છે એને
Electrolytes are apparently normal. Liver function test, bilirubin was normal. SGPT normal, SGOT normal, creatinine is normal. CRP 347 and tropi was 0.006. Next slide. Next slide.
Mehul bhai, the next slide, please.
Okay. So the viral mark part was came into the picture, and so viral part is also being part add-on they have taken, and all were negative. All the viral markers are there, but procalcitonin was 13.9. So it again take us to infection. And infection was the source part, and already prior infection was there. Here, just I would like to highlight 2D echo find parts, and that was in this patient, 2D echo was as such normal. But why it is important on bedside 2D echo in obstetrics part is it will again differentiate along with 2D echo. We have to do the lung scan with the sonography simply. It is a bedside. X-ray may not be available in all obstetric private obstetricians part. But at least they can do the lung scan at the bedside, and that will give us a B line if the pulmonary edemas are there or not there. So it will differentiate between the respiratory cause versus the cardiac point, or fluid overload or any aspects are there. And simple looking at the 4 chambers of the heart, it will give us a very distended vessels or distended part. We can at least, if we regularly put our probe on the heart, even though we don't know how to look at the echo, it is just gives an idea whether the ejection fraction is normal or it is subnormal. If we are able to just see this, whether the ejection fraction is normal or subnormal, it will help us to do some differentiation between the respiratory cause versus the cardiac cause. Yes, in this patient, it was a respiratory cause, and the severe sepsis, because already pre-existing conditions were there. So that's why it is a mainly exacerbation of the respiratory sepsis and going to the respiratory failure. So that was a problem with this case as a part. Next part. So going to the next case.
Yeah,
And
before we begin
because
the
of want
next
of
case,
time,
yes,
want of time, we
exactly.
are skipping faster.
Yes, yes. So the organizers may guide us. We have a total of 6 cases, but then if we have to drop a few cases, it's absolutely okay. Please guide us about what time can be taken. So this is the case 4, and she was a 36-year, that is an elderly primi gravida with a pre-pregnancy diabetes on insulin. She was irregular in follow-up and a poor dietary compliance. The estimated fetal weight was 3,500 grams. At full dilatation, the head was delivered, but the shoulder could not be delivered even after 75 seconds of the head delivery. Next slide. Next slide. So yes, what is the diagnosis for this?
Shoulder dystocia.
Shoulder dystocia.
Very true, shoulder dystocia. Next slide. So the key questions are, what are the risk factors, how we can prevent, and how we can manage?
She's a known case of IDDM, so obviously we should be suspecting this. The 9-month, 36 or 37 week scan should be able to tell us about expected fetal weight, and we should expect that if the weight is on the higher side, there are high chances of shoulder dystocia.
So can you just elaborate any ultrasound parameter which can guide us other than the estimated fetal weight, that there can be a higher chances of a fetal macrosomia and higher chances of a shoulder dystocia? Ultrasound based bisacromial diameter can be taken, and there are charts available for that as per the weight and the ethnicity. So if it comes on the higher side of the normal, then even though macrosomia is not present as per book definitions, which goes as 4 kgs, but still we can plan a cesarean section, not give her a trial of labor. So this one parameter can be requested from the radiologist in case we have the high risk factors. Next slide. Next
Here
slide.
we can say is a DOPE.
Yes.
To suspect in which cases we go for that biacromial diameter. So diabetes, obesity, postnatism, and increased weight gain, rapid weight gain of the baby or the mother during pregnancy.
Perfect, sir.
So that will
these
help
are
us
the
to anticipate and go for that ultrasound findings of the baby.
Exactly. So in cases of DOP, there has to be a request for the bisacromial diameter. A past history of shoulder dystocia again is a very important predisposing factor. So if a mother has given a history or there is a neonatal compromise, definitely, then this time a trial of labor could be given very restrictedly. In most of the cases, it is not predictable. In majority cases, it may occur even without any classical risk factors. Next slide. So, Dr. Maitri, can you just elaborate the management algorithm?
Yes, actually, this is a case of shoulder dystocia, which if we come across to a labor room, we definitely required another gynecologist or a teamwork is required. So you always ask for the help first. Second, macrobot position is required to release the shoulder which gets impacted above the symphysis pubis. And for the delivering or maneuvering, doing any maneuver, you require a liberal episiotomy so that you can insert your hand and dislodge any maneuver if required. You require to go insert your hand inside the vagina. So required a good episiotomy, generous episiotomy. Suprapubic pressure is always required to release the whatever the side of shoulder impacted above the symphysis pubis. By doing this, you can just release the above shoulder, anterior shoulder. You have to first deliver out the posterior shoulder, rotate it, and so that the impacted shoulder will come down in the cavity, and that can be easily delivered out by the rotating the fetal position.
So very well put. we should give some time for watching the drills on shoulder dystocia, because this being a very, very rare complication, it may occur then even with the most experienced obstetrician, he or she is facing it for the first time. So there are videos over the net and other things. You should keep on looking at it, because we have read it in the textbooks, but it often gets rusted because we have never used those maneuvers. Exaggerated Mac-Robertson's maneuver, that is the flexion at the hip joint. Exaggerated flexion and abduction at the hip joint is very important. And one more thing which we often miss is changing the patient's position again to the knee chest position. Like what we saw in the cord prolapse, we often don't resort to this position, but resorting to the knee chest, which is said as the all four position or in a squatting position, would definitely widen the pelvic axis and help in the delivery of the shoulder. It may be a bit inconvenient for the obstetrician to deliver the baby, but then it is very easy to do it. And we have at the medical college conducted studies on alternative birthing positions, and in cases of occipito-posterior and in cases which were high risk for shoulder dystocia, alternative birthing positions are really helpful. Next slide. So these are the key maneuvers which Dr. Maitri has very well said. Next. Next slide. In cases of refractory, that if it is not managed in with all these maneuvers, then what to do? Next slide. So in this cases, we have one more maneuver, that is the Zavinelli maneuver, where it means that you reposit back the entire baby, and that is what we most of the times do. Historically, a symphysiotomy or a cleidotomy, that is the cutting of the clavicle of the neonate, was practiced. But however, I am very sure that in modern obstetrics, we hardly have any experience in doing a symphysiotomy or a cleidotomy. So for us in a refractory case, what option we are left with is the Zavinelli's maneuver, and a very aggressive neonatal resuscitation will be needed in this case. Next slide.
So
Yes.
before proceeding, just I would like to request Archana ma'am, any comments are there as a part? As an expert?
Sir, I think the things are going very well, and important point is that we have to do what Shonali mentioned, also stimulation drill, because a team approach is very, very important. We all may be knowing many things, but to delineate the job and tell that the most specific part, I would like to say that most of the people forget to call the NICU people, because they also need to be prepared to tackle such cases. So only that is one thing has to be delineated, that call NICU people, tell them to be prepared, because your time is very important when you're doing such maneuvers.
So as you rightly mentioned, ma'am, and it's very important you are bringing out that point of obstetric drills. And our Foxy 3HR accreditation part and these other parts are going with the checklist. Even Ashish Bhai has also mentioned about some checklist for embolism. So all these 4-5 situations like eclampsia, PPH, or shoulder dystocia, and embolism and such things, we can always have some checklist ready-made, and we have to be doing obstetric drills, as you had rightly mentioned, and we can go ahead as a part. But as I think participants are reducing, should we continue? Already 8:45, can we wind up?
Yes, I think we can do that. Because this last case which I was to take, most of it was covered in Dr. Ashish here. It was a sudden obstetric collapse, though it was a pulmonary embolism. During his talk on amniotic fluid embolism, he has covered pulmonary embolism. So I would like to drop the 6th case. You can finish off this case first.
I will also, again, the time is
Sorry,
going.
I need to leave. Sorry.
Yes, yes. So not an issue. I think so. We are
Many participants
overshooting the
has to
time.
leave. So I think we can.
Thank you so much.
Yes, yes.
Thank you, MC Patel sir, particularly bringing out again. It's a forum for meeting together, though virtual, but it's a good part so we can meet each other. And all the best, sir, for the next venture. We all are as a team with you.
Yeah, rightly said. We all wish you best, sir. We would like to see you at the top position. And I think Gujarat is with you, sir. And we have to spread it nationwide rather this time.
So big round of applause for both the moderator for nicely conducting the panel, and at the same time for the panelists also to have their inputs and making this panel very interesting and fruitful. And of course, expert Dr. Archana also.
Thank you, sir.
Thank you so much, sir. We really enjoyed the entire program.
Yeah. Thank you so much. Thank you,
Yeah.
Dr. Sonali.
Bye. Good night, everybody.
Good night.
So we are continuing with the same labor room emergency, but some different topics. So next Tuesday, again at same time, 6 p.m. You are most welcome. Link will be the same. Once
Okay,
you are registered in this series, link will be the same for every Tuesday. You can
Okay,
join Tuesday, 6 p.m.
Okay.
Thank you.
Thank you, sir. I think it would be very good academic. Even last full year, we had enjoyed and continuing with so many
Yes.
good topics. I think we all should take the benefit. Thank you, sir, for involving us over here.
Thank you. Thank you.
Thank you.
Thank you.
Monica, we can conclude with vote of thanks. No issue. So it will be my pleasure to propose vote of thanks for all the guests, Dr. Shyam Desai, Dr. Chintan, and Dr. Meenakshi Ben for grace the occasion of inauguration for this webinar, and all the faculty. I won't go into detail with all the names, but all the faculties who have participated in this webinar. So thank you very much. And Corona people, Mr. Mehul in particular for today's webinar, and Dr. Nilesh for entire series. So Corona is with always us as far as educational activities supports are concerned. So thank you everybody.
Thank you, sir. Thank you very much for your excellent webinars.
Yes, Monica, welcome.
Thank you, sir. Good night, sir. Good night,
Good
everyone.
night. Good night.